So I will now turn the workshop over to Dr. Jerry Gerwitz for the workshop overview, which will include a recap of day 1 and an introduction to today's objectives and key question 2 and 3.
So thank you very much, Keisha, and welcome back, everybody. I am looking forward to today, as everybody is. I just want to spend a very few minutes recapping yesterday's session, which addressed key question number 1. We heard a terrific presentation from Dr. Self from the Pacific Northwest Evidence-Based Practice Center, describing a rigorously performed systematic review. And the punchline was, quote, "We identified no evidence on physical activity's effect on long-term health outcomes," unquote. So we also heard a number of presentations from experts in the field. We heard some compelling stories, and we were presented with important research findings that actually went beyond the scope of the systematic review. We learned about the importance of the type and quality of equipment. We discussed heterogeneity, generalizability, and representativeness of study populations. We talked about where registries might be informative, and also the challenges of creating registries in these patient populations. We alluded to intermediate and surrogate measures and endpoints, things like insulin resistance, lipid levels, and VO2 peak, endpoints that might relate to hard outcomes like heart disease, diabetes, and obesity, but which are not true measures of clinical benefit. And we even began to touch on potential harms like detraining effects. So the panel convened following the presentations yesterday and began to sort through what we heard. And I assure you, we remain focused on the task at hand, and we are greatly looking forward to the presentations today. So today we'll be discussing question 2 during the first session of the day and question 3 during the following session. To remind you, question 2 is, what are the benefits and harms of physical activity interventions for people who are at risk for or currently using a wheeled mobility device? And question 3 is, what are the patient factors that may affect the benefits and harms of physical activity in patients who are at risk for or currently using a wheeled mobility device? So one last point, please continue, as Keisha said, to submit your questions and comments. We're capturing everything, and we will be reviewing everything, regardless of whether we have time to address the comments and questions during the discussion. So now I think I am turning things over to Dr. Self.
Hi there. I'm Shelley Self, and we'll be starting here with key question 2, the benefits and harms of physical activity. One of the questions that we asked ourselves was, if you took all types of exercise, could you see a benefit? Because we noticed that there were many studies that reported the 6-minute walk test, the 10-meter walk test, and the MS walking scale. So if we just looked at all types of exercise, did we see a benefit? There were 17 studies, for instance, that enrolled 900 people that did show a benefit when we pooled them on the 6-minute walk test, with people walking a fair distance further. And so what we found is that, yes, we think there is high-strength evidence for benefit in walking in patients with MS. And by high-strength evidence, we mean that we don't expect that additional studies are going to change the findings. This is, unfortunately, the only area in the review where we felt we had high-strength evidence. Next slide. So these next few slides are just forest plots so that you can see the evidence for yourself. These actually, the next few forest plots do have populations besides MS, although they're mostly MS. We put them all on one scale to see what they look like, although the pooled numbers that you saw on the previous slide are only MS. So if you look at the forest plot on the left, you have the study author and year. You also have the category that type of study falls in. Is it aerobic, strength, postural control or balance, or multimodal? Moving to the right, you can see the size of the studies. So these are all very small studies. You can see the point estimate for each individual study, and then you can see the pooled analyses for that category, as well as if you come to the bottom, you see the pooled analyses for overall. So we can see that for aerobic, strength, and postural control exercises, there's definitely the point estimate favors exercise in improvement on the 6-minute walk test. But in multimodal exercise, we see that difference is statistically significant. And so you can ask the question, why is it statistically significant in multimodal exercises and not in the others, although it's trending that way? And one of the answers might be simply sample size. So if you look at the ends that are involved in multimodal exercises, you see a larger N. So it could be we just have more power. And that would indicate that maybe if we added more studies in aerobics and strength and balance, that we might see a significant difference there. Another possibility is that if you remember, multimodal exercise is multi-component. So it's not just focused on one type of exercise, but always has strength and also has either aerobic and balance components or both. So that could be part of the reason why we're seeing a benefit in multimodal exercises. Next slide. So here's the 10-meter walk test. So people did tend to walk a tad bit faster with all exercises combined. And we see, again, a similar thing, and not the trends for the strength and postural control favors exercise. It's statistically significant in aerobics and multimodal exercise, and overall it's significant as well. Next slide. So this is the MS walking scale. Only MS studies that enrolled MS population reported the MS walking scale, and you can see here that the best intervention here is the postural control intervention for improvements on the MS walking scale in patients with MS. Overall, statistically significant as well. Next slide. So now I want to move on to the evidence for NMS where we have moderate strength. So that concluded the high strength evidence in multiple sclerosis. Now we're going to move on to moderate strength. When all studies that reported the Berg balance scale, regardless of the exercise type, were combined, and that's 17 studies enrolling 879 people, but we found moderate evidence for improvement in balance in participants with MS. Also, when we look specifically at balance exercises, 8 studies enrolling 501 people, we found moderate strength evidence for improvement in balance with balanced exercises. When we combined all the exercise types together and looked at depression scales, and this is a different types of depression scales as well, we found moderate strength evidence for improvement in depression when all exercises were combined. However, we did not find evidence for improvement, but instead found moderate evidence for no clear benefit in function with all exercise, when function was the measure used to assess function was the time up and go. Next slide. And here's just the forest plot for the Berg balance scale. Again, aerobic, postural control, and multimodal exercises were significant, and overall it was significant that we can improve balance in MS with all exercises. Next slide. Here's a slide for depression. The only population that actually looked at depression scores in our review was MS. So these are all MS. Actually, the only poolable ones were in MS. And we can see that when pooled, we see a significant finding. Next slide. So now we're going to move, we've completed the moderate strength evidence. Now we're going to move to low strength evidence in multiple sclerosis. And this is where we think that if you add additional studies, it could change the outcome, could change the findings. So we found low strength evidence for improved sleep with aerobic exercises in balance and in ADLs with aquatics. Next slide. We also found low strength evidence in MS for no clear benefit in walking with cycling or in function with robot-assisted gait training, but we did find improved balance scores with robot-assisted gait training. Next slide. We found low strength evidence for improved female sexual function with aquatics and improved function, walking, and balance with treadmill. Next slide. We found low strength evidence in MS for improved function with balance exercises. Next slide. As well as a decrease in fall risk with balance exercises. Next slide. We found low strength evidence for improved function and balance with motion gaming. And here motion gaming means instead of using a mouse or using arrows on a controller to move your person on the screen, you actually have to get up off the couch and move your body, sometimes standing on a balance board, but in some way you have to move your body to play the game. So we found low strength evidence for balance with motion gaming in MS. Next slide. We also found low strength evidence for no clear benefit in function with yoga in MS. Next slide. We found low strength evidence for no clear benefit in walking or in spasticity with strength exercises in MS. Next slide. We found low strength evidence in MS for no clear benefit in function, quality of life, or balance with strength exercises. And this is when, this is the category where the intervention is just strength exercises. Next slide. We found low strength evidence for benefit in walking and balance with multimodal exercises in study participants with MS. Next slide. We found low strength evidence for improved function with dance. To do this, we pooled a trial in MS and a trial in CP. Had we kept them separate, we wouldn't have felt that there was enough evidence to talk about dance as a possible reasonable intervention. So we pooled them and think there's low strength evidence that there might be something there in dance that it can improve function. Next slide. So now we've completed the evidence in multiple sclerosis, and now we're moving on to the evidence that exists that we found in CP. Unfortunately, there was no high or moderate strength evidence in CP. We only had low strength evidence. We did find low strength evidence of improved function with cycling. Next slide. We also found low strength evidence in CP of improved function with treadmill training. Next slide. And we see improved function in CP with hippotherapy. Hippotherapy here does not refer to the mental health therapy that's being done with horses, which has also been called hippotherapy. Instead, what's happening here is the child, typically the child, is riding a horse or riding a horse simulator. So there's low strength evidence for improved function with hippotherapy in CP. Next slide. When we pooled all exercise types together, we found low strength evidence for benefit in function. We also found low strength evidence for benefit in cardiovascular fitness as measured with the VO2 peak in CP. Next slide. And here's the forest plot for the gross motor function measure. You can see that the results favor exercise, although not statistically significant. And so here I just want to point out that we did not require every single outcome to be statistically significant for us to say there was low strength, moderate strength, or high strength evidence. But we did require some statistical significance, and we required the other outcomes to be in the same direction. So showing that it definitely favors exercise or doesn't favor exercise, depending on whether we're calling it for benefit or no clear evidence. So here's an example where it's not, definitely favors exercise, but is not quite significant. Also here we have the pool results for the GMFM66E, the subscale that looks at the walking, jumping, and running. Was statistically significant, giving us low strength evidence for improved function in CP. Next slide. We also found low strength evidence of improved balance with both hippotherapy and with motion gaming in cerebral palsy. Next slide. We found low strength evidence of no clear benefit in walking or function with strength exercises. Next slide. We also found low strength evidence for no clear benefit on function or quality of life with multimodal exercises. Next slide. That concludes the evidence in cerebral palsy. Not as much there as in multiple sclerosis. Now we're going to move on to the evidence in spinal cord injury. Unfortunately, again, no high quality or high strength or moderate strength evidence in spinal cord injury. We're left with low strength evidence. We did find low strength evidence of improved ADLs with robot-assisted gait training, but we found low strength evidence for no clear benefit in function with robot-assisted gait training. Next slide. We found low strength evidence for no clear benefit in depression scores when the different types of exercises were pooled in SCI, but we did find low strength evidence for improved function when in SCI, when SCI studies that reported the Berg balance scale, the 6-minute walk test, and the 10-meter walk test were pooled. Next slide. We also found low strength evidence for improved cardiovascular fitness with aerobic exercises measured with the VO2 peak in SCI. Next slide. However, we also found low strength evidence for increased risk of autonomic dysreflexia when intense whole body exercise was compared with less intense upper body exercise in SCI. And I just want to point out that this study in SCI was really the only study that systematically assessed harms. So they did by far the best job of looking at harms than the other 162 studies in our review. Next slide. So the following slides summarize what I've just gone through. Beginning with MS, we found evidence of improved walking, balance, and depression scores when all interventions were combined. Improved walking with treadmill and multimodal exercises. Improved balance with aquatics, robot-assisted gait training, treadmill training, balance exercises, motion gaming, and multimodal exercise. Improved fall risk with balance exercises. Improved function with treadmill training, balance exercises, motion gaming, and dance. Again, that's when we combined it with the CP trial. And improved female sexual function with aquatics. Improved activities of daily living with aquatics, as well as improved sleep with aerobic exercises. Next slide. I've already talked about autonomic dysreflexia, so go to the next slide. Okay, so I'm sorry, I must have forgotten to say next slide. So I was advancing mine, but not noticing yours. So this is what I just went through for areas in which we saw improvement with exercise in multiple sclerosis. Let's go to the next slide. And here, this slide, we found this is where we found a lack of clear benefit in MS. So we found a lack of clear benefit on walking with cycling and muscle strength exercises, on function with robot-assisted gait training, yoga, strength exercises, and when all interventions were combined, and that's looking at the time up and go test. We found a lack of clear benefit on balance, quality of life, and spasticity when muscle strength exercises alone were used. Next slide. And so before I move on to CP, I just want to mention that if we're not reporting high strength, moderate strength, or low strength evidence for a finding, then it's insufficient. And I didn't pull in all the insufficients here, although you will see the insufficients tomorrow when we summarize key question 4. So now looking at where we found positive findings in CP, we found evidence for improved balance with hippotherapy and motion gaming, improved function with cycling, treadmill training, hippotherapy, dance when combined with MS, and all exercises combined, and improved cardiovascular fitness with aerobic exercises. Next slide. Here's where we found we had some evidence, but a lack of clear benefit on walking and function with strength exercises, and in function and quality of life with multimodal exercises in cerebral palsy. Next slide. So here we're moving on now to spinal cord injury. This is where we found improved outcomes with exercise. So there was evidence for improved function when all exercises were combined, improved cardiovascular fitness with aerobic exercise, improved ADLs with robot-assisted gait training, increased episodes of autonomic dysreflexia, however, with whole body exercise compared with upper body exercise alone. Next slide. And here's where we found a lack of clear benefit on function with robot-assisted gait training and treadmill training in spinal cord injury, and a lack of clear benefit on depression scores when all interventions were combined. Next slide. So that concludes the key question 2. Again, you will see the summarized in key question 4 tomorrow. And also here's a reminder that the full evidence report is available for public comment. Thank you.
Thank you, Dr. Self. Let's welcome Dr. Damiano to present on muscle size matters in cerebral palsy. Greetings, Dr. Damiano. You now have the floor.
Good morning, and thank you to the organizers for including me in this already wonderful conference. I'm going to be talking to you today about and why muscle size matters in cerebral palsy and its interrelationships with physical activity, health, and functioning. Next, please. I have nothing to disclose. Next. So we know that weakness is a major and addressable impairment in cerebral palsy. It should be done starting early in life, and it needs to be done often. We know that the dose in most trials is too little, and the benefits accumulate over time, and this should really be a lifestyle and not therapy. We have learned in CP that targeted approaches for specific muscles are better. We've learned we can grow muscle with exercise and electrical stimulation in CP. And while we know that strength is important for maintaining long-term health and function, it does not address the poor motor control, which requires other approaches. Next. Children with CP have the most sedentary lifestyles among all pediatric disabilities. In fact, ambulatory children are 30% less active and twice more sedentary than recommended for children. And this is, of course, worse for the third of those who do not walk. A national survey showed that only 19% of children with developmental disabilities engage in the recommended 60 minutes of daily activity. And the functional level is really more predictive than the diagnosis. And we know very well about the adverse health consequences that are greater in CP. Next. These are some data from Bjornson looking at step counts in typically developing children and children with CP. CP is classified by 5 mobility levels. Levels 1 to 3 are those that are ambulatory, and 4 and 5 are those who are not ambulatory. On the right here, you see the step counts for typically developing children, which are far less than the recommended 10,000 steps a day. And then you see a drop off as mobility levels change in CP, with those in GMFCS level 3 getting less than 2,000 steps a day. Next slide. Interestingly, many of the best treatments we have for CP weaken their muscles. Muscle tendon lengthenings to reduce contractures, for example, reduce the maximum force that muscles can produce. Orthoses can block some motions and actually can cause atrophy of calf muscles. Botulinum toxin is used to improve the mobility at one muscle in a joint, but it does it by paralyzing its antagonist. And oral and intrathecal baclofen are used often, and these depress spasticity and dystonia, but they also depress muscle activity. Next slide. These are the motor prognosis curves across GMFCS levels and ages. And we used to believe that children, once they attained a certain level of motor function, retain that throughout life. But we're learning that in the lower levels, that motor function actually starts decreasing as young as age 7. And then when you go to adulthood, 50% of adults with CP will lose the ability to walk in early to mid-adulthood. And those that do walk are more fatigued and walk less. And the only outliers are those who exercise regularly. Next slide. Strength is very related to mobility and CP as well. These are data that we obtained in the 1990s, looking at the hamstrings in blue and the quadriceps in red, and showing a linear decline with the GMFCS level, with those in level 1 already 40% weaker than typically developing peers. We also showed that leg strength was highly related to walking speed and CP. Next. These are data we obtained looking at muscle ultrasound. These are cross-sectional data from the rectus femoris in 3 children matched by body weight. And what you see on the left is a child without CP. You see a nice, large, thick muscle with dark muscle tissue. But in GMFCS2 already, you're seeing infiltration in the muscle. You're seeing collagen infiltration around the borders of the muscle, making it stiffer. And by the time you get to level 3, you can hardly even see the muscle tissue with very disorganized borders around it. And we really ask the question, to what extent is this type of damage preventable or reversible? Next slide. Muscle plasticity even starts in infancy. Infants have most of their adult fibers, but do not have any anti-gravity control. And we wonder, when do these abnormal changes start? Well, the data by one of my previous postdocs, Noel Moreau, showed that even in healthy preterms, which is the top graph here, the muscle thickness in the gastroc is half of that of a healthy full term at 6 weeks of age, shown below. Next slide. We know that weakness originates from the brain injury, but it's exacerbated by the diminished activity in CP. Their muscles are normal at birth, but not fully developed. This is why we don't get up and walk as human beings right away. But muscles in CP never receive the normal stress. We know that muscles are the most plastic tissue in the body, and that we all need a set amount of activity to maintain muscle size. And we also know that muscles are more malleable when younger. Next slide. There's 2 ways that muscles adapt. One is to change its size, and that really depends on loading. So if you increase with load, or you decrease with inactivity. The second way is to change protein isoform or myosin heavy chain composition. And this refers to the maximal shortening velocity, or highly supported by the type 2 fibers. And this can be caused by denervation, or it can also be promoted by electrical stimulation or high velocity training in CP. Next slide. Muscle sarcopenia is a term that we were traditionally used in the elderly, but it's now been applied to CP. But what we don't know, or to what extent the factors that relate to muscle sarcopenia in the elderly relate to CP, such as anabolic resistance, which is a blunted response to muscle protein synthesis, inadequate nutrition, which is very prevalent in CP. We know that we need carbohydrates for more endurance and rehydration. We need protein for muscle repair from strengthening. We don't know about the relationships of vitamin D or muscle and CP, although we know that this is very important for the bone health. What we do know is that muscle size and contract tissue is less in CP. And this does affect whole body glucose storage, metabolism, insulin resistance, and metabolic rate. Next slide. Years ago, we were very excited when the Surgeon General announced that people with disabilities had similar needs of exercise, but we know that's not true. We know that people with disabilities are at greater risk and also have greater needs. Next slide. And some of this work has been done by Ed Hurwitz and Mark Peterson and colleagues in Michigan, where they've looked at health risk in adults with CP across these different factors, and everything except for malignant cancer, which is in the middle here, had greater risk in CP with a far greater risk in cerebrovascular disease and osteoporosis. Next slide. And along with this, the healthcare expenditures were also shown to increase. CPs in black, and the left is the reimbursed health expenditures, and the right are those for the out-of-pocket expenses, all very much greater in CP. Next slide. So how do you train strength in CP? Well, load is a stimulus for strengthening, and what you want to do over time is progress from a low amount of load with high repetitions to a high amount of load close to maximum with fewer repetitions. And the individualized starting points vary depending on age, training experience, degree of weakness, and motor control capabilities. And it's recommended that this is done at least 2 times a week. Next slide. So like the data was just shown, the Cochrane review of strengthening in CP shows very underwhelming effects. These are the 3 randomized trials. The combined effect showed it had a minimal positive effect on strength, but basically no significant effect on gait speed and function. Next slide. But there's reasons for this. The first is that study doses and trials are unrealistic, that these trials were only 6 to 12 weeks in duration, and I would challenge any of us to majorly change our function after that amount of exercise. And what we noticed in CP is that those trials also used full body loading. And what happens in CP, since they move differently, is that just strengthens the muscles that are already dominating the task, that are already strong, and it fails to strengthen the weaker ones. So a far more targeted approach is now recommended in CP. Next slide. There's many safety considerations. For example, a type of resistance, free weights are challenging to hold for people with CP, and they may have involuntary or poorly controlled movements that make it difficult for them to use those. We know that progression increments should be smaller and slower in CP, especially important for those that are increased fracture risk. We need to be mindful of not exacerbating limb asymmetries. We know that because there are abnormal biomechanics that they already have, that we need to consider more joint-friendly types of exercise, such as aquatic exercise. And for children, they need to understand how to exercise the proper and safe technique and to be fully supervised. Next slide. There are many barriers to physical activity in CP. One is poor physical capabilities limit them. Many people have comorbidities as well that limit their participation. Interestingly, it makes sense that those who perceive they're good, have good physical competence, are more interested in exercising. So this is a problem for motivation for some people with CP. And then there's a typical lack of appropriate and accessible facilities, attitudes of public and staff towards exercise, lack of trained personnel, supervision, and the financial concerns of, for example, of having to join a gym. Next slide. Just skip the video slides for me. So just talk about some exciting work coming up, trying to get things more into the home and every day. That we have developed an exoskeleton in our lab, and it's fitted with a motor as well as functional electrical stimulation. And what we're showing in the graphs here, these are knee curves, and showing the gray is a normal curve. The red is the person with CP that isn't crouched during the whole gait cycle, and the red box is when we're delivering stim. And what you can see is we actually get a more upright or reduction in crouch when we deliver the stim in those people. And then you assume that over time they'll be using this and they'll be strengthening the muscles over time. Next slide. Similar work is also done by one of our previous postdocs in his research group, where they now have an ankle exoskeleton where they actually resist the motion of the plantar flexion. And what we're showing here is the soleus muscle activity in black for this person. The red shows the amount of torque that's resisted in them. And what you see here with the green is an elevation of 25% more soleus activity. Again, something that can be used over time to strengthen people with every step that they're taking. Next slide. So this is my final slide talking about research recommendations. We still know way too little about the mechanisms of reduced longitudinal muscle growth, contracture development, and epigenetic or genetic effects on or from muscles. There are no studies in CP on anabolic resistance. There are some data on chronic stress and inflammation, but it's inconclusive. We clearly need longer RCTs with more targeting strengthening programs. We need to consider early intervention programs to promote muscle development starting early in life. There are no studies, surprisingly, combining resistance training with nutritional interventions in CP, which would probably be highly promising. And we need more data on effective strategies for increasing participation and regular physical activity, especially in those with non-ambulatory CP. And then again, I think there's great reason to continue to investigate wearable training devices for home and community. So next, and thank you very much.
Thank you, Dr. Damiano. For your presentation. Next, we will hear from Dr. Sherry Blowett on bridging from physical activity to competitive sport. What are the implications? I'll hand it over to you, Dr. Blowett.
Great. Thank you, Keisha, and thank you, Dr. Damiano, for that fascinating presentation as well. So my name is Dr. Sherry Blowett. I'm a physician and assistant professor in PM&R at Harvard and Spalding, where I also direct the Kelly Adaptive Sports Research Institute, and also want to say that I'm also a retired Paralympic athlete in the sport of track and field, wheelchair racing, and I was a teammate of Carrie Morgan's at the Paralympic Games. So everything comes full circle, and it's a pleasure to be here today. Next slide. Just a brief disclosure statement. I did cast a wide net here. Much of this is related to grant support. I served on the scientific advisory board for an app looking at recovery mechanisms after running, and then several boards primarily related to the Olympic and Paralympic movement, as well as the National Advisory Board on Medical Rehabilitation Research. Next slide. So an outline for today, this is going to be a bit of a whirlwind tour. Talk a little bit about how we think about a paradigm shift from physical activity to an athletic mindset and sport participation, as well as the potential risks and benefits, and then thinking about what are important next steps as well as research priorities. Next slide. What I see as the knowledge gaps. So we've talked a lot about dose of physical activity and a lot more work needed in that area, and I'd say the same for sport. We need to understand more about the mechanism of musculoskeletal injury in the para-athlete, and once we understand mechanism, then we can really extend to think about prevention mechanisms. I'm a big proponent of needing to reach athletes themselves and empower them as stakeholders in injury and illness prevention during sport participation. So more work is needed on dissemination and knowledge translation. And a lot of this does loop back to policy. And if you talk to any athlete with a disability, inclusive of wheelchair users, many will say that there are still a lot of ongoing challenges related to the right to participate, the right to sport, and the importance of sport participation as part of our cultural fabric. Next slide. So as it relates to that athletic mindset, there are some important components of when we shift from physical activity to health or physical activity for competition and under a rules-based structure, and that is really the definition of sport versus straight PA. And sports opportunities vary, of course, individual versus team sports, those that are recreational versus elite or highly competitive. And it's important to note that adaptive sport can involve varied levels of physical activity. For example, archery or riflery, which is really precision-based, versus something like wheelchair racing or hand cycling, which is, of course, endurance and very much cardiovascular-based. There has been a lot of move towards defining that access to sport is considered a rights-based issue, and I'll go into more of that later in the talk. Next slide. And much of this workshop has been focused on what are the risks of not engaging in physical activity, and just want to recognize that across our society that is still a far greater problem than what I'm going to talk about today, which is what are the risks when you may be participating a lot, or risk of things like overuse injury. But I do think it's important to understand both sides of this and to recognize that the risk of too much is also an issue that we need to think about in wheelchair users. Next slide. Great. So a quick high level, when we think about the potential risk of adaptive sport participation, I clump it into two primary categories. There's more here, but in terms of what we can cover today, I'm going to talk briefly about overuse versus acute musculoskeletal injury, as well as specific components of sport-related illness, that is autonomic dysfunction, thermoregulation, and pressure injuries. Next slide. From the standpoint of musculoskeletal injury, next slide, please. Much of the work to date has been work coming out of an elite Paralympic athlete population. There are certainly also small studies looking at recreational level athletes or community-based sport, but all of this is still evolving. From the level of the International Paralympic Committee, back in 2012, we launched a longitudinal study that monitors the incidence of injury and illness in elite Paralympic athletes at the Paralympic Games. And this has really been powerful in starting to define injury and illness patterns and how they may vary in the Paralympic athlete compared to an athlete with no disability. And we have found that there are some very key differences. There is, of course, also significant limitations to this work in that this is just a small snapshot of the athlete experience. And certainly more longitudinal work is needed to really define the incidence of injury and illness over the course of a year, for example, or a total training cycle for an athlete in their sport. Next slide. So some of the early trends have been quite interesting and have helped to then define next steps in this work. So if we look at when this study was launched back in London, 2012, we began to see that males and females had similar injury rates, that the upper extremity was certainly most commonly involved, particularly the shoulder, and that acute versus chronic musculoskeletal injury very much tracked with both the sport type as well as disability type of the athlete. So for example, athletes in football five-a-side, which on the Paralympic program is essentially soccer for athletes with visual impairment, the risk of acute injury is quite high versus a sport like powerlifting, which does involve many athletes who are wheelchair users. The risk of chronic musculoskeletal injury was much higher. Next slide. A few figures that I think demonstrate some of these trends. This is looking at the incidence of upper limb injury by age. And here you see that when you look at the proximal upper limb and the shoulder and compare it to the mid portion or distal upper limb, that it does appear that there's something to the increased incidence of shoulder injury with age. That gets back to what we've pointed out in this workshop related to the impact of cumulative load over time, and the fact that athletes are using the upper limb for both sport participation, but also activities of daily living. Next slide. Another figure that supports this is looking at upper limb injury in terms of injury onset, whether it's acute on chronic, or chronic. And here you see that the acute injuries more commonly involve the distal upper limb, whereas those shoulder injuries are more likely to be reported as chronic in nature, also supporting the fact that these are overuse in nature and likely due to cumulative load over time. Next slide. And why is this a real concern? So, when we think about sports medicine, we always have concern when we see a condition that an athlete may acquire early in their life that has implications later down the road in terms of quality of life and function. I think the best correlate is ACL tears in young female athletes. And there's much discussion within sports medicine about the concern about young athletes with an old knee, because we know that acquiring an ACL tear in adolescence leads to early post-traumatic osteoarthritis, and we see female athletes who have osteoarthritis when they're only 30 years old, for example. And although the research is still evolving and we need a lot more work in this area, I think our primary concern is that in the para-athlete or in athletes who are wheelchair users, are we putting athletes at risk of being the young athlete with an old shoulder due to things like early onset of rotator cuff tears, or glenohumeral osteoarthritis, or rotator cuff tear arthropathy that would then lead to shoulder dysfunction even in middle age and certainly into older age. And this is a real concern, and I think that's something that we have to balance with the overall benefit of physical activity and sport participation. Next slide. If we dig a little deeper, we see that these trends do, again, correlate with disability type. This is a sub-analysis of Paralympic data from track and field. And this shows that although in the total athlete cohort, we saw that shoulder came in as number one in terms of area impacted by injury, that really does cluster more so with our wheelchair or seated athletes compared to ambulant athletes who are more likely to experience lower extremity injury. Next slide. And again, if you drill even deeper, you see that sport discipline also matters. So taking it one step further in that same study, we showed that when you look at track and field and those wheelchair or seated athletes, that it's actually the throwers that have a very high incidence of shoulder injury compared to the wheelchair racers where the incidence is much lower. Next slide. And of course, we have to recognize the risk of acute injury. particularly in wheelchair users, one of the primary concerns here is the high risk of something like a fragility fracture in the context of trauma incurred during sport. A wheelchair racer, for example, with spinal cord injury who goes down on the track and may have subtle swelling but no pain or no other symptoms, and having a high index of suspicion for bony injury or other acute musculoskeletal injuries. And we know that there are guidelines available for screening and management of osteopenia or osteoporosis in individuals with spinal cord injury, but more work is needed to look at what is needed in the athlete population. Next slide. Now I want to talk just briefly about illness. Next slide, please. So I'm touching upon three here. Of course, this could be expanded significantly, but wanted to touch upon those that I think are the most important for us to keep in mind. Autonomic dysreflexia, of course, is a consideration for athletes with spinal cord injury, typically at or above the level of T6, although there can be some variability with that. And there is significant concern that a lot of athletes with SCI likely are experiencing low levels of autonomic dysreflexia during sport that may be subclinical and may, of course, evolve into developing clinical symptoms, but many times these athletes are unaware of it and the potential impact that that can have for their longitudinal health. And then also the concern if one were to experience acute dysreflexia on the field of play that could result in a medical emergency. Next slide. Now, there are interesting sport implications here, and particularly the fact that autonomic dysreflexia historically and at times has been used to enhance performance in certain athletes who are susceptible to becoming dysreflexic because it enables those athletes to have a stronger physiologic response to exercise. And we know through the data that is the case. There are some early studies, for example, this one by Schmidt in the early 2000s that looked at release of epinephrine and norepinephrine or circulating epinephrine and norepinephrine during rest as well as maximum exercise in an athlete who was dysreflexic versus not dysreflexic, or a small cohort of athletes actually. And here you see that norepinephrine release is much higher during maximal exercise in an athlete who is mildly dysreflexic. There have been other studies that showed that, yes, indeed, there is enhanced performance with this. For example, a 10% improvement in a simulated road race in an athlete with spinal cord injury who is dysreflexic versus not dysreflexic. And unfortunately, over the years, there were occurrences where athletes would purposefully become dysreflexic in order to perform better. This practice was known as boosting, and there have been measures put in place over the last 10 years or so to try to, at minimum, monitor for this and, of course, raise awareness and educate athletes regarding the fact that it's a dangerous practice and is strongly discouraged. Next slide. Great. Thermoregulation, of course, is a significant consideration for many disability types, inclusive of athletes who are wheelchair users. SCI is one of the biggies, but it can certainly impact any athlete who has impaired autonomic function. And this has significant implications in sport because sport typically occurs outdoors and sometimes in very cold environments or very hot environments. And being aware of the fact that our athletes are at higher risk of heat-related illness or injury, as well as the effects of cold, implications related to things like skin, for example. You know, we have to always keep this in mind as a significant consideration that is a bigger concern for athletes given the environments they compete in. Next slide. And of course, pressure injuries and skin considerations. This was mentioned during several of the prior talks. But of course, in athletes, this is a significant consideration. And there is not a lot of data on this, but we certainly know from, anecdotally and from working with athletes that unfortunately athletes can acquire significant pressure injuries that of course can impact their health and quality of life, and also impact sport performance and their trajectory in sport. There's some fairly good studies in athletes with spinal cord injury, for example, that if you look at what can derail them from being active, that pressure injuries and skin-related challenges is one of the biggies in terms of creating or leading to an athlete who is previously active to becoming very inactive. Sports equipment is a huge consideration here, and particularly when athletes are first getting involved in adaptive sport. Many times they may not be initially very savvy in terms of things like fit of that equipment. They may be borrowing equipment or renting it or using a loaner until they can get their own custom equipment made. And those, I think, are the most high-risk periods of time where an athlete may not be aware of the full risk and also not be using equipment that is customized to them and their body type. Next slide. When we consider organized adaptive sports and consider the benefit above and beyond physical activity, I think it's important to note that there are several smaller studies that do demonstrate a significant impact related to things like mental health, social integration, life satisfaction. Some of these are listed here. And, you know, I think that those of us working in this space really feel like this is likely due to athletes have the opportunity to develop a community and having access to informal peer mentoring and creating friendships of people who have likewise interests and such that can really lead to benefits in the realm of mental health as well as participation in society. Next slide. Also important to note here, of course, that again, not all adaptive sports involve physical activity. So the benefits that I've listed here related to things like mental health and life satisfaction, this is one area where whether you're competing in a precision sport or an endurance sport, these benefits are likely to be at play, which is, I think, a very positive thing. Next slide. When we think about access to sport as being a right-based issue, it's important to note that there has been work in this area. The UN, in its Convention on the Rights of People with Disabilities, ratified in 2006, it did include an article about the right to participation in cultural life, rec, leisure, and sport. The U.S. Department of Ed in 2013 published a Dear Colleague letter that clarified that the right to inclusive education does also apply to sport, particularly in our public schools and universities. And although these are very important landmark pieces of policy and landmark statements, I think that broadly the sport community has not a lot of awareness around this, and we need to continue to educate and show the broader sport community that this isn't just a nice thing to do, but it's rather a rights-based issue and part of any opportunity that we should have across our society. Next slide. There has been some legislation to match with this. So, for example, Tatiana McFadden, a very well-known athlete, when she was in high school, brought suit against the Maryland Public Schools Athletic Association because she was able to train with her team, but not able to be a full point-scoring member of the team. This led to the Fitness and Athletics Equity for Students with Disabilities Act, which enabled her to be a full member of the team. And this has now been mirrored in many states across the country. Next slide. At the NCAA level or collegiate level, there's still a lot of work to do. The NCAA has done a lot around inclusion, and there have been some areas of movement, but across the board, no significant policy changes that have integrated adaptive sport into the NCAA structure or the varsity sports structure. There are, of course, great universities who are doing great work, but these are usually individuals who have a passion for the topic, who are able to push forward programs that live under disability student services or rec sports or intramural sports rather than being at the varsity sport level. So a lot more work to do in terms of inclusion in the collegiate space. Next slide. And just briefly wanted to call out my journey. You know, I acquired a spinal cord injury when I was 16 months old in a farming accident. I grew up on a farm in Iowa. And it was a fairly rural area, and I didn't have immediate access or knowledge of the world of adaptive sport. And as I was getting into elementary school and certainly into adolescence, I was very sedentary, and I was starting to experience the impact of that sedentary lifestyle. I got lucky when one of our track coaches at school learned about the sport of wheelchair racing, saw it on TV, and he reproached me. He said, "Sherry, you should give it a try." And we worked together to figure out the sport and to get the right equipment. And that completely changed my life from the standpoint of opportunities to compete and train nationally and internationally, but also my health. So just to say that this does make a difference, and participating in sport can really put people on a trajectory towards health into adulthood that is long-lasting. Next slide. So what comes next? We need more work on longitudinal characterizations of injury and illness. The Paralympic work, again, is just a small snapshot of that injury and illness experience. And we need more countries and more sports to do longitudinal work to know what's really happening in their athlete population. Next slide. And ultimately, I see it as a world of trade-offs. And we know that there is this vicious cycle of inactivity where people become sedentary and experience all the health impacts of that, as we're discussing over the course of this workshop. And there are trade-offs between the risk of things like musculoskeletal overuse injuries, but the way in which acquiring that injury may actually ultimately have a greater benefit on the health of the athlete because they can live an active lifestyle and avoid chronic disease. So ultimately, I think the most important thing we can do is educate people with disabilities themselves, ensure that they are aware of the risks and benefits of participation, ensure that they're aware of the importance of things like shoulder injury prevention exercises, and empower them to make that risk assessment as an individual. And ultimately, I think that's the best we can do in this world of trade-offs. Next slide. And if you could just go forward, next slide, please. I'm just going to skip these two. And one more, please. And one more. Thank you. So finishing, key points recommendations, certainly adaptive sports and the Paralympic movement are expanding rapidly. We know through the evidence that injury and illness patterns do vary in athletes with disabilities and particularly wheelchair users. Surveillance has provided a nice starting point for understanding the injury and illness experience, but more work is needed longitudinally, as well as thinking about prevention programs and measuring the efficacy of those programs. And I think most importantly, educating our athletes and raising awareness so that they can understand the risk and benefits themselves. Next slide. So thank you.
Thank you, Dr. Blauett, for that insightful presentation on physical activity and competitive sports. We've had some really great presentations today. So next, we'll have Dr. Charles Bombardier with the presentation on physical activity and cognition in spinal cord injury, research gaps and opportunities. I hand it over to you, Dr. Bombardier.
All right, thank you very much for inviting me. Thank you, Dr. Blauett. That was fantastic information, and it's really great to see someone whose trajectory has changed so much through sport. So I'm a clinical psychologist in the Department of Rehabilitation Medicine at the University of Washington, and I want to talk today about physical activity and cognition in spinal cord injury, the gaps and opportunities. Next slide, please. I'm a paid motivational interviewing trainer. That's so some of these studies include motivational interviewing, otherwise no disclosures. Next slide, please. So there's a lot of gaps in this area. Really, we need research assessing the relationship between physical activity and cognition in people with spinal cord injury. We need to know about the type of SCI-related cognitive impairments and which types may be responsive to physical activity interventions. We need to know about the type and dosage parameters that might improve cognition in this population. And then we need to know how we can translate effective clinical-based strategies into more effectiveness studies and reach greater segments of the population to promote health and physical activity. Next slide, please. So generally, what do we know about physical activity and cognition? There's moderate evidence that physical activity positively influences cognition in the general population. There's stronger evidence among children and older adults, and also people with mild cognitive impairment or dementia. There's less evidence in adolescents and middle-aged persons, and most of the evidence is in the area of executive functioning. There's also cohort studies that show that physical activity reduces the decline in cognitive functioning and the incidence of dementia. And also interesting research showing that perhaps mind-body exercise, such as yoga or qigong, may have stronger effects than aerobic exercise in older adults with mild cognitive impairments. So the type of exercise may be critical. Next slide, please. What mediates the effect of physical activity or exercise on cognition? We can look at 3 different levels. Could have molecular and cellular level changes like the HPA axis and neurotropins, neurotransmitters. There's evidence that maybe there's more angiogenesis or neurogenesis. Maybe there's a dampening of inflammation. We can also look at level 2, where there may be structural changes to the brain and functional changes in terms of connectivity, perfusion, neuroelectric potentials. And then also level 3, where it's more on the behavioral level. So exercise may impact a person's stress, their sleep, mood, and pain. And all these could mediate the effect of exercise on cognitive functioning. Next slide, please. So what do we know about people with spinal cord injury? We know that they're underactive, 50% engage in no leisure time physical activity, 25% do not have sufficient fitness to even fully perform their ADLs. It's interesting that people with paraplegia have limited, barely more fitness than people with tetraplegia. We also think that inactivity is modifiable in this population. It's not just related to their level of severity of injury, but also to deconditioning and fatigue, weakness that's reversible. There's lots of environmental barriers, and just habit is a big factor. We also know that physical inactivity is linked to a variety of other health concerns in people with spinal cord injury, such as dyslipidemia and diabetes, insulin resistance, cardiovascular disease, autonomic dysfunction, as well as depression and pain, fatigue, and poor quality of life. So a lot of different factors that physical inactivity may contribute to. Next slide, please. We also know that cognitive impairment is prevalent in people with spinal cord injury. So the majority of the studies report that there is impaired cognitive function in people with SCI relative to control populations. The prevalence of objective cognitive functioning is, it's very variable in the studies, ranging from 10 to 60%. Much of it may be due to concomitant traumatic brain injury. However, there's probably a lot of other factors too, and there's a lot of evidence that even the concomitant brain injury is often mild and resolves over time. Cognitive impairments don't seem to be related to the level of injury. Next slide, please. So what are some of the risk factors for cognitive impairment in spinal cord injury? So there's 3 of 6 studies suggest that depression is a risk factor. Pain has been found to be a risk factor. Fatigue. I also, a newer source or risk factor that's related to cognitive impairment is hypotension and cerebral hypoperfusion. We also have high rates of sleep-disordered breathing in people with spinal cord injury, and then older age. And the main point here is that, unfortunately, there's absolutely no evidence so far that I've been able to find that's linking physical activity or exercise or sedentariness as a risk factor for cognitive impairment in spinal cord injury. So this area is wide open. Next slide, please. So what do we know about exercise and its ability to improve fitness and health in SCI? And that's already been reviewed by Dr. Self, but I'll just cover that quickly here. The most recent published systematic review shows that in acute spinal cord injury, there's low to moderate confidence in evidence that 2 to 3 sessions per week of upper body aerobic exercise at moderate to vigorous intensity, plus upper body strength exercise that can improve cardiorespiratory fitness and power output and strength. And then in chronic spinal cord injury, there's low to moderate evidence that 3 to 5 sessions per week of upper body aerobic exercise, moderate to vigorous, for 20 to 44 minutes can improve respiratory fitness, strength, and body composition and cardiovascular risk. So there's no evidence, though, on the potential effects of fitness training, exercise training on cognition, and needs to be included in these types of studies. Most studies are also clinic-based, and so there's limited potential to reach the larger population of people with spinal cord injury from these studies. And one of the main questions I was asked to address is really, can community-based telehealth interventions improve fitness and reach more people? Next slide, please. So I want to talk a little bit about harnessing behavior change theory and telehealth to improve fitness and maybe even cognition in spinal cord injury. Next slide, please. I think we're all familiar with social cognitive theory as a model for understanding health behavior change, especially exercise promotion. But I've been influenced a lot by more complicated health behavior change model that was published by Schwartzer back in 2011. And this model is broken into 3 types of patients or people: pre-intenders, people who are not really ready or thinking about the behavior change in mind; intenders, people who are thinking about that activity or thinking about undertaking that activity, for example, exercise; and then actors, people who are already engaged in that activity. And what this model does is it kind of lays out what are the key health behavior factors or cognitive factors related to each level of readiness in people, from pretenders through intenders and actors. Next slide, please. And what's important to notice really is that in laboratory studies, you've got people over to the right who are already actors. They already believe they can exercise. That is, that they have high task self-efficacy. They already believe that exercise will benefit them. That is, that they have outcome expectancies that are positive and helpful in terms of the benefit. They also have a risk perception that indicates that they believe that the risk of not exercising may harm them, and they are on board with that. They have formed intentions to exercise, And they had figured out ways to overcome barriers to exercise and have support to exercise. So looking at this model, you can see kind of where all the people in the laboratory studies end up. They're far over here to the right. They've already been able to have all these other meet all these other criteria in terms of health behavior change. But if we want to extend our research into the broader population, we have to address these issues ahead of time. So next slide, please. So what we have to do if we're going to be able to use telehealth or other strategies to motivate people in more community-based trials, we have to look at all these other factors. We've got to be able to figure out ways to increase task self-efficacy, outcome expectancies, perception of risk. We have to help people form intentions. We have to elicit ways to begin action planning. We have to figure out how they can maintain their self-efficacy as well as develop it. And we have to be able to help them figure out ways to cope with barriers and cope with relapse and solicit resources to continue their exercise. So we've got a lot of work to do on the front end here to get people over to the place where they can become intenders and actors. Next slide, please. So I want to really just call out some studies that are a particular study now that I think has done a good job in terms of using some of these behavioral factors to get more people exercising. And this is a case in multiple sclerosis. So this is Sandroff's work back in 2014 where they chose a single accessible behavior that's so important. They just chose walking. So in spinal cord injury, if we want to translate that, we'd probably use wheeling or arm ergometry, but they chose an accessible behavior, which is really important. They had developed a website where they had the content based on social cognitive theory. They taught important skills like self-monitoring and goal setting, and in order to bolster the person's outcome expectations and self-efficacy. And they identified barriers and facilitators and so forth and worked on those. And they worked on training people over 6 months. They also used strategies to give people objective feedback and show that they're getting closer to their goal attainment. So they used pedometers in this case. And they also promoted self-monitoring, so using a logbook and using that as a way to self-monitor and self-reinforce for goal attainment. They also use goal tracking software. So that's really important in terms of setting goals and then measuring your attainment of those goals and progress toward those goals. And then they use behavioral coaching using video chat platforms. And they just basically use, social accountability, someone else helping you monitor your change to promote adherence. They use this to discuss barriers and facilitators. And they covered this content over their website. So nice example. Let's look at the outcome of that study in the next slide. So they randomized 82 people, 1-to-1 to 6-month progressive walking, intervention or weightless control. And they measured, in this case, the oral symbol digit modalities test, which is a measure of cognitive processing speed. They found a significant time by condition by disability level interaction on the SDMT. Those people with mild disabilities showed moderate improvement on the SDMT scores, and those with moderate disability showed minimal changes. So it was a nice study that was reasonably powered. It was theory-based. And they did some subgroup analyses. It was generalizable, a generalizable intervention because they chose walking, and they used inactive controls. In terms of weaknesses, they had unblinded outcome assessment and no assessment of the social cognitive mediator variables. Next slide, please. So I want to also call out one really nice theory-based behavioral physical activity study in spinal cord injury as well, done by Ma and colleagues. This is a study of 28 men and women with spinal cord injury, randomized 1-to-1 to an introductory personal training program. Plus, they had these 8 weekly 15-minute behavioral coaching sessions via Skype versus a weightless control. And what they use is they use that health action process model that I described before, and they tailored the intervention to where the person's stage and the behavior change techniques that were most appropriate for them. And their whole goal was to increase moderate to vigorous physical activity. They used self-reported MVPA and accelerometers and then also fitness testing to measure their outcomes. And they also found a significant group by time effect of the intervention on self-reported MVPA, as well as accelerometer data, and also absolute fitness measured by VO2 peak. They also did a nice job in this study of measuring the mediators, the HAPA-theory variables, also showed improvement. So it's a nice, small but adequately powered trial. It's theory-based, had multiple objective outcome measures, looked at mediators. The weaknesses that they didn't have a measure of cognitive function, and they used inactive controls. Next slide, please. So the key recommendations really, I think, for this area of research is that we need to really use the expertise we have in other mobility disability groups and convene conferences and other forums in which we can kind of share our expertise across these mobility disability groups to foster collaborations and share expertise so that we can become more adept at measuring cognitive functioning across these groups, figuring out how to use the more advanced behavior change models, and using the techniques other investigators develop to promote more community-based trials. We need correlational research in the area of spinal cord injury just to begin measuring the relationship between cardiorespiratory fitness, physical activity, and cognition in people with spinal cord injury. In those studies, we probably have to control for traumatic brain injury. We need to begin to have experimental research. It would be easy to just add measures of cognitive functioning to some of these laboratory studies to see if we're getting any effect on cognition. We also need to begin looking at the type and dose of exercise and how that might influence cognitive functioning. And I'm especially interested in mind-body types of exercise because that may be more accessible to people with spinal cord injury. We need to include some mechanisms like respiratory fitness, depression, sleep, pain, fatigue, blood pressure, and cerebral blood flow in these studies. And then we really need to begin, if we're going to expand exercise promotion, physical activity promotion in this population, we really need to look at and use these more complicated, comprehensive behavior change models and use the techniques available to us like mobile technology and accelerometry to spread the influence of physical activity to a larger population. Thank you.
Thank you, Dr. Bombardier, for that thorough presentation and recommendations. So our last speaker for Key Question 2 session is Ms. Karen Korb, who will address Beyond the Checkbox, Are Wheelchair Users Really Included? Perspectives on improving access, inclusion, participation, and adherence to physical activity with wheelchair users. I'll turn it over to you, Ms. Korb.
Thank you so much, Keisha. Appreciate all my previous panelists for their very insightful information. My name is Karen Korb. My pronouns are she, her, hers. I'm a disabled white woman with blonde hair wearing a multi-pattern top and a black scarf. I'm a wheelchair user for close to 40 years as a result of a spinal cord injury, a gymnastics vaulting accident to be specific. I am WebExing in as an uninvited guest of the Muncie Lenape Lands. I, similarly to Dr. Morgan and Dr. Blauett, am a high-performance athlete, currently happily retired. I'm a two-time Paralympian in the sport of wheelchair tennis. Ironically, tennis was a sport I didn't even like. But what I know now is what influences much of my work today is that it wasn't the sport or the training I didn't like. It was the systems of leadership within the tennis organizations because they had the power to decide who was worthy of being included to participate and who wasn't. I was a health equity advocate way before I ever knew what that even was. I am currently the Policy and Public Affairs Coordinator for Lakeshore Foundation, and I want to thank the NIH Office of Disease Prevention for this opportunity. Next slide. I have nothing to disclose. Next slide. Barriers to physical activity. Regardless of my many personal and professional accolades, my life as a white privileged wheelchair user is often spent demanding equitable access to simply exist, let alone being physically active. It is also spent internalizing ableism as a means of survival in a world that is not built for me or many of my siblings with spinal cord injury and those who use wheelchairs for mobility. We are beholden to archaic medical model systems designed to fix us, as we are so often seen as broken. The end goal of walking, which was emphasized by one of the presenters yesterday, it is not the end goal for many of us. as shocking as that may be for many of our audience members today. However, health and well-being are. We are often forced to act and behave more like non-disabled people as a standard so we can fit in and receive the critical access that we actually have a right to so we can participate as best we can. We are often the subjects to be studied and not those who lead the process of the study. What I continue to learn is that the people closest to the pain of exclusion of physical activity should have significant decision-making power in creating the research and its focus. The most victimized and vulnerable in these processes should be the ones leading. They're not. And why not? Who is creating and leading the research design? Who is participating? What does the outreach and engagement resemble? Does it include diverse intersectional representation of those with spinal cord injury and wheelchair users? The key question is, what are the benefits and harms of physical activity interventions of people who are at risk for or currently using a wheeled mobility device? When I process that question as a wheelchair user, it is difficult for me not to be insulted. When you say you are at risk for using a wheelchair or wheeled mobility device, it makes it seem that using a wheelchair is a bad thing, when I know that from my lived experience that is not. Similarly to the phrase, sitting is the new smoking. I could easily regurgitate data from existing research and what the common barriers for physical activity are for wheelchair users. However, it's the macro lens of disability justice I want to highlight here. I recognize that parts of this may be outside the scope of the systemic review, yet critically important nonetheless. Next slide. As we collectively move forward and we begin to use the long overdue lens of health equity to create and assess our work, may this be an important reminder, as Dr. Morgan also mentioned in her plenary yesterday, that the barriers that inhibit participation and the daily harms endured by disabled people are created by systems that have historically not included all of us in the first place. My presentation is credited to and adapted from the Health Justice Commons. I'm in this space to elevate the 10 principles of disability justice and aim to focus on principles 1, intersectionality, principle 2, leadership of the most impacted, and 9, collective access. Next slide. This is Patricia Byrne, who's the co-founder and executive director of SINS Invalid. The disability justice primer that I'm referencing was created by a collective of diverse and intersectional disabled people. It centers specifically disabled, queer, trans, and non-binary people of color. The disability justice movement is over 15 years in the making and is an ongoing movement. And I want to very specifically acknowledge my white privilege within the entirety of this presentation. Next slide. Intersectionality. The slide is of Audre Lorde, is a Black woman with an afro. We do not live single issue lives. Disabled people are many things and they all impact us. We're not only disabled, we are also coming from specific experience, race, class, sexuality, age, religious background, geographic location, immigration status, and so much more. The term intersectionality was first introduced by feminist theorist Kimberly Crenshaw in 1989 to describe the experience of Black women who experience both racism and sexism in very specific ways. Why is this important? Barriers to physical activity are not just a lack of ramps or physical infrastructure for wheelchair users. Race, sex, sexual identity, age, disability, socioeconomic status, and geographic location all contribute to an individual's ability to achieve physical activity as a component to good health. It is important to recognize the impact that social determinants have on health outcomes of very specific populations. For example, many of our wheelchair-using participants at Lakeshore Foundation do not drive. They rely on paratransit or some form of accessible transportation to come to our facility. No transportation, no access. And while I've heard often mentioned telehealth and its proponents, and that's great, it's cool, but it doesn't address the fact that having a disability means you're twice as likely to live in poverty where the limitations are socioeconomic, and you may not be able to afford internet. And you may also live in a rural area that does not have specific Wi-Fi access or any Wi-Fi access at all. Next slide. Leadership of the most impacted. In order to get solutions, we must center the most impacted disabled people, those who are the most vulnerable, those who are on the margins of the margins. Who is most impacted? What do our social determinants of health address? Conditions in the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks, correct? We know the social determinants of health have a tremendous impact on people's health, well-being, and quality of life. Safe, accessible housing, transportation, neighborhoods, racism, discrimination, and violence, education, job opportunities and income, access to nutritious foods, and physical activity opportunities. What if there was leadership of the most impacted in each of those areas? Those who do not live with our privilege. Physical activity would be higher on the priority list for wheelchair users, and we would be witnessing active change because that would be prioritized. The curb cut effect, written by Angela Glover Blackwell, gives a powerful example. Disabled activists pressured Berkeley city officials back in 1972, and they wound up installing its first official curb cut. It would become, in the words of a Berkeley advocate, the slab of concrete heard around the world. Everyone benefited from the curb cut, not only people in wheelchairs, parents pushing strollers, and workers with heavy carts, business people, rollerbladers, skateboarders, those who use multimodal transportation. The access movement was led by wheelchair users who are most impacted at the time. I ask again, what if leadership was comprised of disabled people, intersectional and diverse wheelchair users, and we are prioritized? Access would be prioritized and resourced, and then everyone benefits. Next slide. The third principle is an anti-capitalistic politic. You can read the slide. We're not going to focus on that because I'd like to get down to the other ones. Next slide, please. Commitment to cross-movement organizing. Next slide. Recognizing wholeness. And while I'm running through these slides, I just want to mention that this is the layers of the principles that are incredibly important. The laying over of your existing work and the research that is being conducted and that is going to be conducted. Next slide. Sustainability. Next slide. Commitment to cross-disability solidarity. I know that was mentioned in the previous presentation. Next slide. Interdependence, which is we meet each other's needs as we build towards liberation, knowing that state solutions inevitably extend into further control over our lives. We often in this industry talk about independence. Independence is the mantra, but we really need to change that language. The goal isn't independence because we must recognize that we're all interdependent. Next slide. The principle of collective access. As disabled people, we bring flexibility, creative nuance that go beyond non-disabled minded normativity to be in community with each other. How do we unlock human potential, as well as creating opportunities for ease of movement and activity within our communities? So much of what comes out of research, in a sense, is shaped by society's beliefs, and in turn shapes the beliefs of society. So if we have systems of systems that continue to leave people out, we have to change the system. Dr. Victor Pineda, who's an internationally renowned urban planner, who is also a power chair user at University of California, Berkeley, he studied digital and infrastructure development projects within cities. Over 1,200 active projects. And guess who was completely left out? They looked at each of the proposals and identified that people with disabilities and older persons were completely left out of these projects. They found that 96% of the projects didn't even mention people with disabilities, chair users, or older persons as beneficiaries or stakeholders. we would be reapplicating the same kind of exclusionary barriers unless we come together. He talked about some focus areas, and the first focus area was if the barriers to physical activity for wheelchair users are infrastructure related, do researchers who don't have disabilities know what physical accessibility laws are? If you have intersectional disabled people leading your research who happen to be wheelchair users, I would bet they would know, and it would highly influence the work. The second area of focus is your current research leadership talking about these issues of exclusion? Are they putting budgets toward identifying these barriers and actively removing them? The third area is institutional capacity and coordination. You cannot just solve these barriers within one department. It needs to be interdisciplinary, a cross-agency approach to solutions, always disability-centered and preferably disability-led. The fourth area, my favorite, is attitudes. Are there outdated attitudes and language that prevent wheelchair users from living up to their human potential and becoming physically active? A great example of collective access is the work around building inclusive playgrounds and parks designed for children with disabilities and wheelchair users. Inclusive playgrounds and parks that encourage physical, social, and sensory play while creating connections among all children. Next slide, collective liberation. Next slide, discussion, questions, and comments. I want to focus on the last comment. You cannot transcend what you do not recognize. Key recommendations. Oh, next slide. Key recommendations. And this is in a broad spectrum. Conduct qualitative and quantitative research utilizing the 10 principles of disability justice framework to recognize barriers that ableism in academia systemically creates and perpetuates. 2, convene disabled-led, disability-centered interdisciplinary working groups to create best practices on eradicating the antiquated and continued use of the medical model of disability in research. Next slide. 3, review and revise curricula to include and prioritize social and cultural models of disability. And lastly, review and revise current mandatory departmental diversity, equity, and inclusion trainings that include and prioritize disability within the training that is also led by intersectional disabled persons. In conclusion, we can make a substantial impact not only in reshaping our values, but in reshaping how research design is created and implemented by prioritizing and using the disability justice principles in our work so that we create places and spaces with disabled people, not just for disabled people, so that wheelchair users want to be physically active in those spaces when our human dignity is protected and our highest health potential can be realized. Next slide. Thank you for the gift of your attention. And I credit this presentation to the National Institutes on Health, Justice Commons, Mordecai, Cohen, Edinger, Orme, Bagari, HGC staff, Patricia Burns, Sins Invalid, Dr. Jim Rimmer, Dr. Carrie Vanderbaum, Lakeshore Foundation, and the National Center on Health, Physical Activity, and Disability. Thanks so much.
Thank you, Ms. Korb, for that valuable perspective on improving access, inclusion, participation among wheelchair users and disability research. We will now invite all of the key question 2 presenters to join the discussion and Q&A sessions as moderated by Dr. Gerwitz. Thank you all in advance for sending your questions through the Q&A pod. We will continue to receive your questions throughout this session. Dr. Gerwitz, you may begin.
Sure. And Keisha, could you just give me some advice about timing, how we're going to use our time? And how much time
Yes, so we will have 40 minutes for this discussion session. We are adjusting the time because we had a late start, so you will get the full 40 minutes as allocated.
So we're planning on going till half past the hour and then a 10-minute break?
Yes.
Okay.
And after you complete the discussion and Q&A, I will give some highlights, and then we will then take our break.
Okay.
All right.
Okay. So thank you for those fantastic presentations, everybody. Let me moderate the discussion section, and I'd like to ask the panelists in the following order if they have any questions or comments related to the presenters. What I'd like to do is first ask Kirsten, then Boris, then Daryl, Kelly, and Noel. So, Kirsten, you have the floor.
I actually don't have any questions right at this point.
Boris?
Yes, hi. Thank you all to all the presenters. And this is actually first question, or the question that I have actually is directed towards Karen, although others are obviously also included in terms of your insights on this. Thank you for introducing the concepts of sort of the social determinants. As a public health person, the social determinants of health play a key role, and I think with wheelchair users and the world of disability, this plays a key factor. But I want this sort of to interplay with where our group may be going, which is with recommendations in the future. And it intersperses a little bit with what Charles had talked about a little bit, which is the use of tele, right? So yes, you use that adjective tele, or that prefix tele, with telehealth, tele-exercise, tele-research, tele-investigations, however you want to put it. How do we do this best in trying to make sure that we are all inclusive and yet using 21st century technologies, if you will, to better both the research as well as the health outcomes?
Well, thank you for the question, Dr. Shishniak. I think the abridged answer is to recognize within the research design the population that you're leaving out. And when you recognize the population that you're leaving out, which is a significant part of our disability population, and this is why I referenced the intersectionality and the leadership, we must bring that forward, because we already know in the non-disabled populations what that data looks like. And we must recognize the disaggregate numbers of this other population.
Great. Charles, any comment from you in your sort of cognition studies and the world of tele and how it intersperses with social determinants and inclusivity?
I think there's a number of things we can do. I mean, first is to ask people with disabilities that we're seeking to work with, where do they get their trusted health information? What are the mechanisms, the sources of information, and what are the forms of technology that they use? We've done studies, telehealth studies, but we've also done telephone studies. So I think we need to know what is accessible to the population we're seeking to work with, and where they get the information, and then try to match and tailor our modes, our means of delivering services to those individuals. Definitely, I think we, as Karen pointed out, there's a lack of access to internet services and so forth, but I do know that at least that's one step toward making these services more accessible beyond the usual laboratory-based studies.
Great. Well, thank you.
Daryl?
I'm here. Just give me a second. There it is. So first, I want to thank the panelists for really great presentations. I've really found them very eye-opening, and I have just a few questions. First, I want to talk about translation, and I think as I believe this was Diane's presentation with regard to athletes, para-athletes, and then Charles' presentation with regard to sort of this notion that there are actors and that most of our the research that's being done is being done in these spaces or with these populations that are really sort of engaged and have in some way made the decision to get involved in physical activity. So I want to ask you, with regard to translation of at least some of the results that we've seen, what do you think are the barriers to translation to sort of engage the current persons who are not involved in physical activity? And then the other question is there you know, one of the things in which you highlighted was sort of the dose of the intervention. It's essentially the amount of the length of the intervention is being inadequate to really have the kind of impact. And so I wanted to get a sense of, given that we're working with a population that seems to be the most engaged in terms of who we could do these interventions with, as well as the barriers to translating those to populations that are not engaged, and the dose is relatively small. What do you think of studies that would then try to increase the dose and then engage that sort of that non-engaged population? So, and Sherry, if you have comments on this, I'd appreciate it too.
Sure, Dr. Gertz, would you like me to start? Happy to follow your lead.
Yes, please.
Okay, great. So first off, Dr. Gaskin, thanks. That's just a fantastic question. You know, in the comments that I provided around sport and an athlete population and thinking about the potential risk of engaging in a high level of physical activity in sport, you know, I did comment upon the importance of doing more to think about dissemination and knowledge translation. And as I listened to all of our talks, I mean, I realized certainly along the way that it all really gets back to the points Karen made regarding always remembering that the stakeholders of the research need to be involved in the research. And, you know, maybe that means planning a protocol or thinking about what outcome measures should be used, but at minimum, it should involve thinking about how those results are disseminated and can actually have impact on the community. And speaking from the lens of an athlete myself, who then evolved into being a clinician and engaging in research, I can certainly say that although there was work happening at the time in which I was competing, I had no idea that there were people who were engaging in research and thinking about athlete health and safety and paradigms to promote athlete health and safety. You know, it just never made it to me as an athlete. Mm-hmm. And I think that's still a problem. And I think that's something we can be more deliberate about. You know, even with a group like the International Paralympic Committee, for example, you know, we're working towards creating better links between the people that are leading on the sports science, sports medicine agenda and the Athlete Council, for example, so that when new information comes out, that we are directly thinking about things like use of social media or, you know, tools that are athlete friendly and that we know will be interesting to athletes and reach them in a way that they listen and that it's impactful. And ultimately, I think it's about empowering athletes because, you know, we can learn as much as we want to do great research that shows that, you know, a certain sport may lead to a high risk of shoulder injury. But if we don't then tell those athletes that are participating in the sport that that's the case, then, you know, we certainly don't have the impact that we can have. So I don't have all the answers, certainly, but I know that to me, as all of this moves forward, we cannot forget that piece because ultimately respecting athletes' autonomy and understanding that they're the end user and the most important stakeholder in this work is just so important.
I'd like to comment a little bit, if I could. I think that the use of that HAPA model can help us. What I learned in my latest study, where I tried to do a physical activity study in people with spinal cord injury, we have our stakeholder group. They told us we really want help to become more physically active. That was the top concern they had about coping with their spinal cord injury. When I recruited for this study, I went out to hundreds and hundreds of people and I think I was able to randomize about 16 people. So, I mean, the gap between, what I'm pointing out here is that from that HAPA model, there's very few actors, there's a lot of intenders, and there's a lot of people who are pre-intenders. And a lot of intenders, they'd like to become physically active, but really can't get there. And so that's where that model helps. I think it's almost like we have to have an intervention before our intervention. When I advertise for this study, what I need to do is I need to make it clear that there's a risk of physical inactivity, probably even in my study recruitment materials. I probably have to do more to emphasize that people can become physically active. In this particular study, I didn't do enough to really show people we're going to give you resources to become physically active in whatever way you want. It reminds me of a study I did years ago where we had one woman who her physical activity program started by her walking out to her mailbox, and then once a day, and then multiple times a day, and then around the block and so forth. So how can we emphasize that we're going to set the threshold so that you can start and you can start from wherever you're at, and you can do whatever you want. So I think kind of keeping it open. And then the third thing is really to increase that sense of that the intervention we're trying to use with you, physical activity, we have to increase the sense in that person that it's going to benefit them somehow. So we have to work on that too. So it's almost like this. It's an intervention before the intervention that has to have some of those components if we're going to move those people from, a pre-intention to intention, or from intention to action.
Any of the other presenters wish to comment or respond to Daryl's questions?
So I just wanted to extend off of sort of what Daryl was asking, and a little bit, I guess, maybe Chuck, start with you. So one of the things that came up in quite a few of the presentations, and thank you to the presenters for giving us such informative talks today. So I'm thinking more about sort of the dosing questions that everybody raised, like what do we know about dosing? What do we need to know about dosing? And related to that, intensity, what should we be looking at in terms of what do we need? I guess we don't know a lot about dosing, except maybe we don't really know what is not enough and what is too much to make really solid recommendations. And that will differ for different people, which I think is what Chuck was just saying. And we need to sort of meet people where they're at. But I have similar questions about sort of intensity and what would the recommendations be about assessing intensity. I think Chuck is the only one who really talked about some spinal cord injury studies that look at sort of intensity of intervention and what may at least have some lower moderate evidence. But just sort of what would the recommendations be around what we should prioritize in terms of understanding for dosing and intensity of physical activity?
I'm as a psychologist, I'm the last person who should comment on intensity. We need an exercise scientist to probably comment there. But I do want to point out that the mechanism of action really makes a difference, because if the mechanism is maybe more alleviating depression is going to improve their cognition, then maybe the level of intensity doesn't have to be as great. Or if it's sleep improvement, maybe the intensity doesn't need to be as great as if we think the mechanism is more, angiogenesis or something else. So I think, I look forward to other people commenting on intensity and duration.
So this is Diane. I'd be happy to comment. So just as an example for strength training, if you're talking about intensity, for strength training, you need to get at a high load or it doesn't affect the muscle. So physiologically, you need to get at a high load. You can do it too high or too many times, and you can overtrain or you can not give the muscle enough rest. So intensity is important physiologically. Some intensity is going to be too much and some maybe not be enough for certain things. Intensity is a big part of dosing, and it, just like Charles said, it really relates to what are the goals of your intervention. The intensity for somebody who wants to be at an Olympic level is clearly very different than someone who's at a recreational level. But, dosing is so important. We had a American Physical Therapy Association pediatric section just had a research summit on dosing. And I think, it's such a key question, and it involves duration. And duration's a big factor in the research. If you look at the research and it doesn't change function, the reason is that all the studies, just because nobody can afford or, keep people through studies for more than, several weeks to months, you don't make major changes in function doing strengthening for a short period of time or doing any activity, but it builds up over time. So that the research is really misleading in the fact that strengthening or aerobic training or a lot of these different things don't change functional parameters very much, and that we really need to look over the long term. The other misleading thing that many people talked about is that all of this is a lifestyle and that none of us can maintain our health and functioning unless we regularly use physical activity. And so the message that you can do anything for a short term, that it's not something, that's why I hate for it to be called therapy or to be therapy, because it's really lifestyle. It's really every single day you need to move, use your muscles, and train at some level. And all those things are big factors in both research and trying to get dosing recommendations.
Thank you. Kelly?
Hi, I just want to talk briefly about, in a very crude way, when we did look at dosing and intensity, what we found that the studies were doing is that if we looked at studies that showed a benefit in at least one of the outcomes we were looking at in MS, the studies that showed a benefit had on I'm using the median rather than the mean. The median is 24 sessions. And for those that showed no benefit on any of our outcomes, the median was 17 sessions in MS. Both of those were over 8 weeks. So just to give you a little sense there. In cerebral palsy, it was 24 sessions for benefit, 20 sessions that did not have a benefit on any of the outcomes we were concerned about. In MS, the benefit was, for benefit, it was over 12 weeks. The ones that showed no benefit were over 8.5 weeks, so a little bit more spread out in cerebral palsy. In spinal cord injury, we had less evidence here, but we did find, again, 4 more sessions, so 40 sessions in MS in those trials that showed a benefit versus 36 sessions in those that did not. And again, this is only the outcomes that we were looking at. And I also want to say that that there was, you could have a 10-session study over 2 weeks that showed a benefit, but then you could have a 70-session study over, 50 weeks that did not show a benefit. So there's still a great variety there, but that just, from a crude sense, is what we found when we looked at what the studies showed.
Thank you.
Kelly, do you have any comments or questions?
Thank you to the presenters, and I do not.
So thank you. This is Jerry, I have a few questions and observations and comments. So realize that the qualifications of the panelists are that they know very little about the topic, if anything. So one thing that's become clear to me in listening to these presentations is how important equipment and technology is when I believe Diane talked about exoskeletons or muscle stimulation. These things didn't really come up in the systematic review. So I think a naive group of panelists might be thinking, well, physical activity is walking. And it seems like we should be thinking in a much broader way. So maybe, Diane, could you comment on that and educate us further?
Yeah, I think, it's the same sort of with any kind of adaptive equipment. I mean, we know that, a lot of people face challenges when trying to exercise, and you need to find ways for them to exercise. And just like Sherry told the story about just getting the right wheelchair, the racing wheelchair, I mean, you need to have the right equipment. And so that's more passive technology, like wearing a brace or doing something like that. And now we're thinking about assistive technology. So, for example, if you can't perform a movement, how can you ever practice it? If you can't, for example, just dorsiflex your ankle, but you have the capability in there somewhere to be trained, how do you make that happen? And that's where things like electrical stim can come in and grow the muscle over time and make it strong enough to do it. And then newer technologies, I mean, the problem is we have to, to exercise, you need to have a lot of equipment or go somewhere to do it. If you really could have, again, the tele exercise where you're having somebody wearing something in the home that you can be monitoring, and basically it's a personal exercise device. If you think of a world that does that, where you can provide resistance training, you can provide stretching, there's so many things that are possible to do, or you can just have people that aren't able to walk very well on their own, just give them enough assistance that they're able to do that activity every day in their personal lives. So it makes them more functional while it's training them. In some cases, we design these devices to basically be worn for a certain period of time, and then you back away from it, and you just sort of use it as a maintenance dose. But people may need it for their lifetime. So I think for people with physical disabilities, there's so many other exciting things coming along that would basically promote their ability to access physical activity.
Thank you.
Dr. Gurwitz, could I briefly comment on that one as well?
Oh, please.
Yeah, just wanted to say to present kind of another angle of it too. I think that dovetailing on the prior comment about the social determinants of health and some of Karen's comments around access and rights-based issues, I think that one thing that we've seen as it relates to broad engagement in physical activity and sport for wheelchair users is that the equipment can often present such a barrier, and the ability to obtain that equipment actually goes back to being a social determinants of health issue for many people because it's expensive. And in order to participate well, i.e. in a way where you can actually fit in the equipment, engage with it, go out, get your heart rate up, get a physical activity, exercise stimulus, the customization of equipment and ability to get that equipment is so difficult for so many people that it becomes a major barrier. And I just want to call out that so much of that goes back to socioeconomic challenges, rural versus urban challenges, access to having knowing the right people for how to get out there and obtain that equipment and be fit for it appropriately. I do think there's probably a role for telehealth, telemedicine, teletechnologies to assist particularly in individuals with disabilities in more rural communities with that. I think that NICPAD is doing a little bit around that. But, just to say, I think there's an equipment component as it relates to how can you use equipment to get the right dose. But I think even taking a step back from that, there's a much broader social determinants of health component to that for wheelchair users.
Thank you, Sherry. I guess I had another question or comment that I'd like Karen to respond to. And so, Karen, are you there?
Sure am.
Okay. So what I was listening to in your presentation, I was trying to reconcile the relationship between science and policy. And you gave a couple examples like curb cuts and inclusive playgrounds, which can increase access and activity. And remember what we're trying to do here is look at science, look at the results of RCTs in terms of influencing policy. But in your presentation, I was getting a sense of, well, do you really need RCTs? Do you really need randomized controlled trials to make policy that's important and needed? So I wonder if you could respond to that.
Yeah, I appreciate the question. I would never say that we didn't need it because I think there's enough to go around. There's room for all of it. Again, I want to recognize that we're in a very privileged conversation. And, physical activity, needs to be, people need to be participatory at every single level. And we are very white-centric with everything that we do. And when we have these randomized controls and these groups, we must prioritize. And, Dr. Rimmer talked about it in exclusionary criteria. We must prioritize inclusive criteria. And when we're doing these, when we're promoting these research initiatives, who are we asking to participate? This is the entire crux of the presentation. And I don't know if I'm answering your question. You might want to rephrase it.
No, I may not have been giving you an answerable question, or maybe it's more of a rhetorical question. So, but thank you.
Yeah, I think it's very important. I mean, we should have randomized controls, but who are the participants and who is leading? Because if you look at our panel and look at who is reviewing this, what do you see? And that is the question that I pose.
Thank you. So I am seeing some questions come in, and there's one question or theme that seems to be showing up, and I wonder if all the presenters could comment on this. Do you feel that there's a gap in research that is truly focused on the highest risk groups, including those who already require wheeled mobility versus those who don't? What are your thoughts about that? Do you want me to call on you? Diane, why don't you take a stab at this?
Sure. I mean, I know in cerebral palsy, families are always telling us, and when we have research priority conferences with them, that we're not focusing enough on people that are GMFCS 4s and 5s, which are people that are not ambulatory. And just because, again, if we had more people participating in the research who had those disabilities, they could help inform us sort of what their needs and what's so different, because it's easy for me to think of a child that only has a mild motor impairment, how they can improve their walking, but it's much more challenging for me to understand the problems of people that have far more mobility. So I think that it's a huge problem. Clearly the issues of SES and where people live are also big barriers. I mean, there's so many things that we could really learn a lot more from each other working together.
Anybody else?
Dr. Gertz, I could just say that I think as it relates to the sport aspect, that one of the challenges and considerations for the future is that when we think about a sport, say something like wheelchair basketball, for example, most of the, even if we were to do a study, say where we were to, work with the wheelchair basketball team over the course of a season and monitor their load as well as their musculoskeletal injury, just providing an example, to try to say, well, this amount of load may lead to overuse injury. The challenge is that very few studies actually ask those players about their load off the court. And a wheelchair basketball player can be an amputee and ambulatory with use of a prosthesis for most of their time outside of sport, or they could be a paraplegic and a full-time wheelchair user for all of their activities of daily living. And so just to throw out that I think it's a slight twist. It's not exactly answering your question, but it's a slight twist to the point of, at least from a sport angle, having to do a better job in understanding, like, what's that total load of ambulatory time versus wheelchair use, and how might that impact injury and illness.
Thank you. Chuck, can I ask you a question?
Sure.
Okay, so I'm a geriatrician, and if I wanted to study cognition in association with aging, the approach that would often be using, if I wanted to study cognition with advancing age and the relationship to physical activity, the approach used would often be a cohort study of lots and lots of people, hundreds if not thousands, who you would follow over time. That doesn't seem possible in this area. And I wonder if you could reflect on that a little bit.
Yeah, I'm not. So you're saying that it's not possible to do cohort studies in aging populations where we're measuring physical activity and cognition at least 2 time points? Is that what you're saying? It's just not feasible?
I guess I'm trying to make an analogy between how we would study the relationship between physical activity and cognition in a population that did not need, was not at risk of wheelchair use, just the general population, and this population.
So you're kind of, if I'm following you, you're kind of saying that in the populations we're studying, we're never going to have these kinds of numbers. We're never going to find a large enough sample of aging people who are at risk and be able to follow them over time because of the limited numbers that we'd be looking at.
I guess
there'd be huge multi-site studies, probably worldwide.
It would be hard to take an observational approach.
Absolutely. Yeah, absolutely. I mean, they would be huge multi-site studies and probably have to be, like I said, worldwide maybe to get the sample sizes. So they'd be very, very, very expensive. You'd have to translate your measures into multiple languages. I mean, they seem like that seems not feasible at all to me to do that. We're having to extrapolate from the general population to these disabled populations, and it may not be valid extrapolation. So.
I am going to ask the panelists if they have any more questions or comments.
Dr. Gurwitz, I just want to address a comment that you just made. You were asking him, addressing a population that may not be at risk for wheelchair use. So I would just want to point out that we're all at risk for wheelchair use. Whether you're born with a disability, whether you acquire it, like myself, or you age into it. And so I think it's very important that we normalize the use of adapted equipment to be functional and create opportunities for physical activity with whatever that equipment is. That's all I have.
Okay, Karen, thank you for making that point. Really appreciate it. Okay, any other comments or questions from the panelists before we end this session? Okay, hearing none, I think we can conclude this session. And Keisha, if you can direct us toward a break and when to resume, that would be great.
So I know that we had a couple more minutes before the break. I'm not sure if there were any questions that you wanted to pose to the panelists, Dr. Gurwitz, that were received in the Q&A pod.
Okay, since I will, so within the next 3 minutes, and since I'm part of this group, I'm going to read this question.
Okay.
The panelists comment on physical activity needs and outcomes for people over 50. What we know and what we should be looking at. Anybody want to comment on that?
Dr. Gertz, I can pop in just to say that from the lens of the work that I presented, there's increasing recognition that we need to, for people who are wheelchair users who are quite active in adaptive sport through their adolescence, early adulthood, even into middle age, including them in some of the longitudinal work so that we understand the impact of being involved at a high level on illness and injury later in life. And there's frankly just very little data about that. From the lens of athletes with no disability, there are groups like, for example, the World Olympians Association, which have a great database of retired Olympians that can do surveys and ask people about, you've been retired from sport for 20 years, but do you have shoulder pain, hip pain, back pain now, or other symptoms? And we just don't have that type of database or organization yet as it relates to sport for people with disabilities, but it is on the radar and it's a goal. And I think it's just a really important question. So thank you to Edward who asked the question.
Thank you.
I think that Shelley has her hand up.
That was an old hand raise.
Okay, thanks. Is there one more question, Dr. Gurwitz, you'd like to squeeze in? And I will take your guidance.
I think we're close to time right now, so why don't we're within 30 seconds, so why don't we close this session and move on to a break?
Okay, thank you. So many thanks to our presenters and our moderator for such an engaging portion of the workshop. Before we actually take our break, I just wanted to highlight a couple of points because these are things that have been shared maybe in the chat or the Q&A that I think everyone can benefit from. Just to let everyone know that recordings of the workshop will be available at on the ODP website in a few weeks, and we're going to post that in the chat now. If you would like to request additional resources, please email us at nhp2p@mail.nh.gov. And also, we noticed that there was some questions and comments in the WebEx regarding the EPC's systematic evidence review, and we want to encourage everyone all the participants to share your comments and review it at the link that is available on the ARC website. We posted that in the chat as well. It's going to remain open for comments until December 8th. So we will now take a 10-minute break to refresh and prepare for the next part of our workshop. To help us keep on time, there's a countdown clock that's going to appear on the screen, and we ask that you please return so we may begin on time with discussion of key question 3. Thank you.
Testing audio 1, 2, 3. Testing audio 1, 2, 3.
That's great. We hear you loud and clear. Thanks so much.
Great, thanks. Okay, bye-bye.
Sure thing. Bye.
Keisha, are we ready to begin?
Yes, thank you. So welcome back, everyone. Good afternoon and good morning to everyone joining us from the Central, Mountain, and Pacific time zones. We hope you had some time to refresh and are ready to begin. Key question 3. What are the patient factors that may affect the benefits and harms of physical activity in patients who are at risk for or are currently using a wheeled mobility device? We will hear from 5 presenters on this key question. Following the presentations, we will hold a discussion and Q&A session moderated by Dr. Gerwitz, our workshop and panel chair. So questions are being received through the Q&A pod, and we will answer them during the discussion session. I will turn it over to Dr. Marion McDonough from the Pacific Northwest Evidence-Based Practice Center to present on this key question.
Thank you, Keisha. My name is Marion McDonough, and I am professor in the School of Medicine at Oregon Health and Science University. I'm also the co-director of the Pacific Northwest Evidence-Based Practice Center, which conducted the systematic evidence review to support this conference. So as Keisha said, I'm going to continue presenting the evidence findings of our review. So next slide, please. Thank you. So this slide is to remind us where we are in the systematic review. Yesterday and earlier today, Dr. Shelf presented the methods and the main findings of our report, evidence on the long-term health outcomes, and then this morning, intermediate or surrogate outcomes of the potential benefits and also potential harms of physical activity in wheelchair users. And now I'm going to tell you about our findings on the assessment of what factors may alter or affect these outcomes. Next slide.
So this is the key question as it was written for our review. And in order to evaluate the effects of factors on outcomes in a systematic review, we have a few different options that I want to go over before presenting the findings. First, we evaluate individual studies' analysis of these factors, so their subgroup and other types of analyses. Second, we can look for studies that report the results stratified by these factors, so we can conduct our own analyses across multiple studies. In this review, however, although there are a lot of studies included, none of the studies reported outcome according to subgroups of interest. So we didn't have the opportunity to conduct those types of analyses. Finally, the last thing we can do if these are not available to us, these options, is to make indirect qualitative comparisons. So we would compare studies that are conducted in these important subgroups that are otherwise similar. So we'll have quite a few of this option on the following slides, so I'll point those out when we get there. Next slide. So only 4 studies conducted their own subgroup analyses on the effect of the interventions according to patient characteristics or other subgroups, and no study evaluated harms according to baseline patient characteristics. The 4 studies, 2 each in patients with multiple sclerosis and spinal cord injury, evaluated the effects of interventions according to patient characteristics or factors such as baseline functional ability and weight. So the participants were in their early 30s for studies of multiple sclerosis and late 30s to mid 40s for spinal cord injury. And as was typical in this review, there were more women in the studies of multiple sclerosis. Looking at the other characteristics at baseline, we see that both sets of the studies were at the more mobile end of the range or spectrum. Next slide. 2 studies of patients in MS conducted subgroup analyses, and both of these studies were conducted in Iran. In multiple sclerosis, a trial of core stability training in 69 women found that improvement in strength and balance outcomes was greater in participants with higher levels of disability at baseline. So they were comparing EDSS levels scores of greater than 3.5 to those of patients with scores less than 3.5. The second study, a study of 63 participants with relapsing remitting MS, evaluated upper and lower extremity interval cycle training and analyzed the effect of baseline weight categories of normal or overweight according to BMI. Although fatigue and depression scores both improved with exercise on the whole, no interactions were found between baseline and endpoint weight status, so BMI category, fatigue, or depression. Next slide. So in participants with incomplete spinal cord injury, 2 small studies found that those with better function or more recent injury had better response to the physical activity interventions. And both of these studies were conducted in North America. The first is a secondary analysis of a small study looking only at responders. This was a study of activity-based resistance and locomotor training in participants whose spinal cord injury had occurred more than 12 months before enrollment in the trial. The analysis evaluated predictors of response according to baseline characteristics. So they found that patients with less disability, so comparing AIS grades of D versus grade C, and those whose injury occurred less than 3 years versus those whose injury occurred 3 years prior, greater than 3 years, had more improvement on the 6-minute walk test. However, changes on the other outcomes, the 10-minute walk test and the timed up and go, were not significantly different based on these patient factors. This analysis also evaluated injury level, lower extremity motor score, and the use of a walker prior to study, but did not find that these predicted improvement on any of the outcomes. The second study here is a small crossover trial of participants with a more recent and incomplete spinal cord injury, so the injury within 7 months of enrollment. This was a comparison of endurance walking training and precision walking training. Improvement on the 6-minute walk test here was significant with endurance training among participants who had a better walking speed at enrollment than those with a lower or slower walking speed at enrollment. Next slide. So none of the included studies conducted subgroup analyses based on patient demographics. So we conducted only indirect qualitative comparisons of the effects of these factors where we had similar populations and interventions were conducted either entirely or mostly in different demographic groups. With age, within the multiple sclerosis and spinal cord injury populations, there was either inadequate variation in age across the studies or heterogeneity in the outcomes reported by age group to allow us to assess the impact of age. So, for example, across 15 studies of aerobic interventions in patients with spinal cord injury, there was not a wide variation of age in the enrolled participants, a median age of 43 with a range of 33 to 56 years. Additionally, the studies that were in participants in their 30s predominantly evaluated oxygen consumption outcomes, while those in patients in their 50s more commonly evaluated walking outcomes. However, in cerebral palsy, we were able to do at least some indirect comparison. Across 22 studies of aerobic type exercise, 13 included children, 8 included adolescents, and only 1 included adults. Globally, the findings, the direction of effect, and the statistical significance was similar in studies of children compared with studies of teens, with benefits being found on walking outcomes in about half of the studies and improvement in gross motor function in over a quarter of the studies in both groups. Unfortunately, for sex, race, or ethnicity, the studies just did not report these demographic factors in a way that could be evaluated even indirectly. Next slide, please. None of the studies also reported subgroup analyses of the results of the interventions according to population. This is mainly because each of these studies were conducted in a single population and not multiple, so they didn't include patients with cerebral palsy and patients with MS. So we were left with indirectly comparing the results. So we looked at the findings of our own meta-analyses, where there was evidence for more than one population for the same intervention type and same outcome measure. Next slide. So for aerobic interventions, for example, the 6-minute walk test was not improved in a study of adults with CP or in studies of patients with MS. So we didn't see a clear difference according to population for that outcome. However, for VO2 peak, there appeared to be variation across populations. So studies in participants with multiple sclerosis did not show a benefit, but studies in patients with spinal cord injury did show some benefit. Next slide. So for strength interventions, the 6-minute walk test was not improved in a trial of children with cerebral palsy or in 3 trials of patients with multiple sclerosis. So again, there was no clear difference according to population based on an indirect comparison. Next slide. With balance interventions, however, there was too much variation in the findings to indicate a pattern. So the 10-minute walk test was not improved in MS or spinal cord injury studies. However, the timed up and go was improved in studies of patients with cerebral palsy and spinal cord injury, but not in studies of patients with multiple sclerosis. And finally, the Berg Balance Scale was improved in studies in all 3 of the populations. So again, just a lot of heterogeneity there. Next slide, please. So finally, the final group we looked at is multimodal interventions. And similarly here, we found that the evidence just did not provide a pattern. In a single study of patients with cerebral palsy and in studies of patients with multiple sclerosis, there was a lack of consistency in the direction of findings across the outcomes. The 6-minute walk test improved in both groups. The timed up and go was not improved in either group. And the 10-minute walk test results just differed by population there. Next slide. So in summary, I've got a few summary bullets here, but basically there's very little evidence to guide us on which factors affect the outcomes of physical activity in wheelchair users. While we note that patients with MS who were less ambulatory at baseline improved more with stability testing training, and those with spinal cord injury who were less impaired or had more recent injury at baseline had better results with aerobic interventions, we feel that these findings are really more hypothesis generating, so more useful to guide future research. Thank you.
Thank you, Dr. McDonough, for that very thorough evidence synthesis for key question 3. Our next presenter is Dr. Edward Hurvitz discussing growing up active with cerebral palsy. Welcome, Dr. Hurvitz.
Thank you, and thank you so much for the invitation. It's really an honor to be here with this wonderful panel and all these wonderful speakers. Really learning a lot today. So I want to talk about growing up active with cerebral palsy. I'm from the University of Michigan, and our group has done a lot of work looking at adults with cerebral palsy and some of the outcomes, the health outcomes that happen in their life. And I want to talk about how that applies to the question we have in front of us today. Next slide, please. I have nothing to disclose. Next slide, please. So here are some of the knowledge gaps that I want to highlight. So first, research assessing the effects of different levels of physical activity among individuals with cerebral palsy who use wheeled mobility device, what the effects are on common medical issues such as risk of chronic disease, skeletal fragility, fitness, pain, fatigue, and functional loss. We need to do that kind of research to enhance the understanding of how physical activity fits into an overall health promotion plan. We want to understand more about personal, physiological, and psychosocial factors and how they influence participation in and the effects of physical activity. And conversely, how physical activity affects these factors and their outcomes. And we need to do more exercise research in cerebral palsy. It's focused on younger and higher functioning participants, leaving a significant knowledge gap related to adults, especially older adults, and those who are in the Gross Motor Functional Classification Scale, GMFCS 4 and 5, who are the wheelchair users. Next slide, please. So let's talk a little bit about growing up with CP. There are many, many wonderful things about growing up with CP, and I'm not going to be talking about any of them. Instead, I'm going to be talking about things like increased risk of chronic disease. That includes cardiovascular disease and stroke, musculoskeletal syndromes, mental health issues, and chronic kidney disease. And we've published in all of these areas talking about the increased risk that we've identified. Skeletal fragility is a big issue. Fractures are associated with increased mortality and decreased risk and increased risk of chronic disease. And individuals with cerebral palsy are at much higher risk for what we call non-traumatic fractures. Of course, fractures always require trauma, but we're talking about really like low trauma fractures. And those are the things that we've seen that have increased this risk. There is pain and fatigue, which are really common complaints that happen in the cerebral palsy clinic. We see a very high percentage of this among our patients. Next slide, please. People who grow up with cerebral palsy have a poor level of fitness. This is shown in many, many studies of many groups. Dr. Damiano talked about this a bit. There's obesity, there's decreased aerobic capacity, there's decreased flexibility and coordination, there's decreased strength. There's low levels of physical activity and increased sedentary activity. One of the things that we need to think about when we think about physical activity in individuals with disabilities is not just exercise and sport, but also the massive amount of sedentary activity which accompanies their lives, and how do we break that up more? There's a pattern of early functional loss in cerebral palsy. Studies have shown that individuals with cerebral palsy who have bilateral cerebral palsy, like spastic diplegia, lose walking function in their fourth decade when they're 30s. And people that are what we would call hemiparetic, more involved on one side than the other, who we tend to think about being very mildly involved, actually report losses of ambulatory function when they get into their 50s and their sixth decade. Next slide, please. So does physical activity help people with cerebral palsy? Well, of course it does, because physical activity helps everybody. It certainly helps in cerebral palsy. As Dr. Damiano presented, it increases strength, it increases fitness. Now, does it increase bone density? I don't believe we have good evidence of that. Does it help with the mental health problems? I'm sure we don't have evidence of that, and the same for risk of chronic disease. Does physical activity decrease pain? I don't believe we've been able to show that. There certainly increases participation and socialization just by the very nature of doing the physical activity. Does it improve life outcomes like driving, employment, relationships? Does it improve independence? These are things that we don't know. Next slide, please. Well, let's look at a few of the factors that may influence how physical activity affects people with cerebral palsy and what kind of effects it can have on their life. So let's talk about that gross motor functional level that I talked about. Most studies done on individuals with cerebral palsy focus on the GMFCS 1 through 3, who are the ambulatory population. It's just easier to get those folks into exercise programs. But the GMFCS 4 and 5, the wheelchair users, are more difficult to do studies on and are often excluded. There's an image here from a study that we did looking at GMFCS 4 and perhaps some of the more involved GMFCS 3 individuals. We put them onto this device called a New Step, and we had them do 40 minutes of exercise. It was really just a feasibility study to show that the exercise is possible, it's not damaging. They were further studies, but there's much more study that needs. Next slide, please. Okay, I'm not seeing the slides move forward. Okay, thanks. Next is age. Let's talk about different ages and how that can affect physical activity. So children who are in school would normally go to gym or be involved in after-school physical activities really spend that time in therapy, which is sometimes a kind of physical activity, but not really a pattern of physical activity. It's not something that they take into their home lives, and so they don't grow up with a pattern of physical activity. So here's a question. Do adaptive sport programs lead to long-term increased physical activity? Does it establish that pattern of PA? What about adolescents and young adults? Well, studies have shown that individuals with cerebral palsy often lack social skills that are associated with initiating meaningful physical activity. So being able to get a group together or invite someone to jog with you or that kind of thing may be something that's a challenge for individuals who grow up with a disability. Their lifestyles are associated with more sedentary activity. There's all the computer time for, especially during the pandemic, school, and then work, and then socialization. All these things are done now on the computer. We're all sitting a lot more, but individuals with disabilities, probably even more. And for a child with a disability, it's harder for parents, or for an adult with disability, harder for caregivers to get them to a physical activity, perhaps more than so than a typically developing individual. Now, for older adults, that's a question I asked in the last session. Older adults, as I've talked about, have more medical complications, which is something to consider when thinking about physical activity. And there's almost no research and risk and benefits of physical activity in individuals with cerebral palsy who are over 50, over 60. Next slide, please. Access. Dr. Damiano talked about this a little bit, the idea of accessible equipment, transportation to fitness centers, access to expertise in appropriate fitness programs, having guidelines for individuals with cerebral palsy for exercise. Dr. Rimmer presented a paper that our group published with a group from the Netherlands on guidelines for individuals with cerebral palsy, but there really isn't enough of that. How about access for things like pathways for wheelchair hiking and other access to adaptive sports, which fortunately is growing? Next slide, please. We have to think about the effects of treatment. I always like to think about what are we doing to these kids. So all the spasticity intervention we do during childhood for kids with cerebral palsy, what are the long-term effects on function? Well, there have been some studies that show long-term effects that were positive for the selective dorsal rhizotomy, but we don't know as much about the others. What's the long-term effects on fitness? Does doing spasticity management with their children increase their physical activity as they get into adolescence and into adulthood? We don't know. What's the long-term effect on bone and muscle structure? There's been some real concerns raised about toxins and how they affect muscles, but we don't have all the answers on that. What about orthopedic surgery that's done during childhood and fitness and physical activity outcomes? Does getting to proper alignment and kinesiology, does that help physical activity outcomes, or does it hinder them, or is there no effect? And then what about spasticity orthopedic interventions on adults themselves? does that change their ability to participate in physical activity? Next slide, please. I mentioned a lot of medical issues, and these are things that have to be concerned about as factors when we think about physical activity. For example, many individuals with cerebral palsy have seizures and take seizure medications, which may interfere with certain aspects of their participation. Seizure medications we're also finding now have some effect on bone structure, and so may have some physiological effects, which may interfere with physical activity or lead to worse outcomes in physical activity. I mentioned higher risk for cardiovascular disease, so more medical monitoring is required at a younger age. People with cerebral palsy may see the kind of cardiovascular risk that we associate with being 50 and 60. They may see that when they're 30 and 40, and so we have to start thinking about those things. There's the higher risk for chronic kidney disease, respiratory disease, other disease states, which lead to more medical appointments and care time that takes away time from physical activity. There's a higher risk of mental health issues, so depression and anxiety, which can impair participation. So does treatment of depression and anxiety, does that help to increase physical activity? On the other hand, what's the effect of physical activity on mental health issues? All things that we need to study and we need to know better. Next slide, please. Bone health. There's a high risk of fractures, as I mentioned, especially the non-traumatic fractures, things that happen during range of motion, during transfers, or during a fall that most of us wouldn't think about as a fracture risk. Fractures are associated with increased mortality and chronic disease, so it's an important consideration for this population. Does weight bearing increase bone density? Does it do that as children? Possibly. What about as adults? Does more weight bearing actually increase bone density, and how much weight bearing? We don't have a good understanding. And what about medical treatments like osteoporosis medications? Does that increase safety from fracture during physical activity? Next slide, please. Nutrition. In many individuals, cerebral palsy has a big problem. They'll have poor nutritional status, and this can be associated with decreased levels of participation. There's been some great work done on this, which showed increased hospitalizations by Rich Stevenson, increased hospitalizations and other problems, which will interfere with their ability to go to school and just participate in any kind of activities. On the other hand, there are high rates of obesity in individuals with cerebral palsy. Oral motor coordination problems and poor swallowing can interfere with proper nutrition, and GI mobility issues and constipation can also interfere, making someone just not feel like being physically active that day. Next slide, please. There's personal and environmental factors. There's what we call now, should change the slide to social determinants of health, your socioeconomic status and other issues like race and gender and so forth. Some of these things may limit access, affect transportation, affect access to nutrition. There's cognition issues. There may be a poor understanding of the need for physical activity in some individuals with cerebral palsy. And then there's just scheduling. There's self-care needs, work needs, family needs. These are things that are hard enough with a disability, without a disability, and then with a disability, there's all the added time burden. Will greater physical activity and greater fitness have a positive effect on social outcomes like employment, relationships, and independence? Next slide, please. So let's talk about some key recommendations. I think we need to conduct longitudinal studies examining chronic disease risk and the prevalence of pain, fatigue, and functional loss in adults with cerebral palsy. And we need to understand how physical activity impacts these things and how these things impact physical activity. We need to conduct studies that examine how personal and physiological factors, and particularly medical and surgical intervention, affect long-term fitness and influence participation in physical activity. We need to encourage studies that include all levels of function and types of physical activity, including GMSCS 4 and 5, as I've mentioned, and wheelchair activity in people of older age. We need to develop more clinical guidelines for practitioners to encourage and advise on physical activity. So I thank you for your time and attention. Again, I thank you for the invitation, and looking forward to hearing the recommendations from the panel.
Thank you, Dr. Hurwitz, for sharing that informative presentation. Our next presentation on the topic of complex and changing lives, participation over time among people with MS, possible implications for research on physical activity to people who use or may use a wheelchair, will be presented by Dr. Marcia Finlayson. Introducing Dr. Finlayson, everyone.
Good afternoon, everyone, or good morning for those of you who are over on the West Coast. Thank you very much for the opportunity to join you today. I'm joining you from Kingston, Ontario, where I'm a professor in the School of Rehabilitation Therapy. So my disclosures, I do receive research funding from the MS Society of Canada and have received speaker honorariums for unrestricted educational events that target people with MS that were sponsored by Biogen or San Genzyme. So, next slide. So my objectives in the 15 minutes that I have is just to share some insights that I've gained from 20 plus years of research with people with MS that might inform thinking about the study of physical activity among people who use or are at risk of using wheelchairs. So although I've collaborated on several studies of physical activity among people with MS, this topic is not core to my research program. So therefore, in preparing this presentation, what I've tried to do is reflect on what my team does and has learned in our work that could inform thinking about the study of physical activity in this particular group of people, and really what our insights might suggest in terms of challenges that these research might have as it continues to evolve. Next slide. So I just want to frame a little bit of context for my responses. So my work is almost exclusively in the area of multiple sclerosis, which is a long-term condition, often diagnosed in people as young children into adulthood. And so people often live with the condition for 40 years or more. During this time, they experience a high degree of variability in symptoms. The consequences they experience very much due to changes in life roles. There's different levels of visibility of the condition and the symptoms that they experience. And then as a result, variations in the stigma that they may experience because of their disability. I am an occupational therapist by profession, and my professional orientation is to really focus on enabling people to do what they want to do, they need to do, or they're expected to do in the context of their everyday lives, and really to be able to find a way of enabling that through matching people, their activities, and their environments to get them to a point where they're really engaged in the things that are important and meaningful to them. From my research perspective, I have two broad areas, both intervention research and qualitative, and I'm going to be drawing on this experience as I present my issues. So I very much have a focus on fatigue management, self-management, and also the self-management of consequences of MS, particularly falls and caregiving supports. And the last piece that I'm going to draw on in terms of my presentation are just qualitative work I've done on the experience of aging with MS and also the motivations that people have for successful self-management. So next slide, please. So I'm going to share four insights that I think are relevant to work on physical activity among people who use or may use a wheelchair. And that is the goals of meaningful participation, the ripple effect of MS, time changes everything, and the importance of building on strengths. Next slide. So the first insight I'd like to share is that the goals that people set and what motivates them to engage in activity is really the ability to choose those activities that are personally important, meaningful, and satisfying in the context of their everyday lives. So consistently in our own work, people have told us that they have decided to participate in our symptom management interventions, not to manage the symptom, but to be able to do an activity that they wanted or needed to do. So in other words, symptom management, and even the improved health that might result in that is not the end, but it's the means to the end. And that is doing what's important in the context of their everyday lives. So Carrie Morgan talked about this yesterday and noting that her engagement in physical activity has been motivated, at least in part, by the desire to be included and to have social connections. She also talked about her own physical activity research and the goals that her research participants have set. For example, being able to dress independently, do car transfers, or drive. So the goal was not solely the doing of the physical activity, but what physical activity could lead to. So in our own research, we found very similar themes. People with MS have consistently told us that the reason they seek to manage symptoms is to reduce the impact of these symptoms, which in turn continues to allow them to engage in things that they want or need to do. This engagement has provided our research participants with a sense of continuity in their life before MS and before disability. So these kinds of observations are consistent with findings from a recent meta-analysis by Roberts and Bannigan that examined the dimensions of personal meaning that occur through the engagement in activities. And these researchers found that health and well-being is supported when people are able to do activities that provide them with a sense of fulfillment, restoration, social, cultural, and intergenerational connection, and that help shape their identity. So unfortunately, part of this insight is it's relatively rare to see these broader outcomes captured in studies of people with MS or in physical activity studies. And so there is an attempt to include some of these broader measures. We often, when there is, we tend to see measures of quality of life, which often ask people about the frequency of performing activities or problems or limitations in performance of a set of activities. What we rarely see is questions that ask people about the problems or limitations in engagement in activities that are personally important to them. So there are research teams out there that are working to expand options for outcomes in these areas. And one of these is the community participation indicators from Alan Heinemann's team. What's really interesting about this tool is it not only asks about the frequency and importance of a set of activities, but I think what's more important is that it also asks people to reflect on whether or not they're doing an activity too much, enough, or not enough. So this evaluation is important, as sometimes doing something less is actually better outcome than doing something more. Next slide, please. So what are the challenges arising from this insight? And what does it suggest for research on physical activity among people who use or may use a wheelchair? So first, I think this insight about the importance of meaningful participation is that we need to choose outcomes that matter to stakeholders, the people who are being targeted for the intervention. It also emphasizes the importance of going beyond short-term, medically oriented outcomes that occur proximal to the physical activity intervention. We need to go beyond narrow definitions of function and move to participation and engagement in the context of everyday life. So while physical activity may be the goal for some people, for others, it will be a means to a broader endpoint. And we need to capture these endpoints and really understand the benefits of physical activity interventions. If we don't, I think we risk missing important outcomes. And perhaps we miss the opportunity to capture broader psychosocial harms of not being physically active. Yet these broader outcomes really mean that we need good quality outcome measures that have flexibility to capture what matters to people with a broad array of interests. And we need to articulate the conceptual connections between physical activity and broader engagement in meaningful activities. And these connections may not be as linear as we tend to think. So there are many factors that may have little or nothing to do with these broader outcomes and physical activities. So we really need to think about other confounding factors that may influence them. And many speakers have identified these already. So environmental supports, financial accessibility to opportunities, access to equipment, weather, transportation. So going to these broader incomes is going to be challenging because there's many confounders that we need to sort out for accurate interpretation. Next slide, please. So the second insight I'd like to share is that the impact of the disease or disability goes far beyond the person with a condition. family, friends, and others who are important to the person. In case of my work and people with MS, they also experience significant impacts. And I anticipate that this also applies to the other populations that are being addressed in the workshop, people with cerebral palsy or spinal cord injury. These other individuals are affected by the disease or the disability through changes in their own routines, activities, roles, responsibility, and associated stressors. Family and friends take on many, many other things, either out of necessity or concern for the person with the condition. So we really need to consider these broader ripple effects as we attempt to design, test, and scale up physical activity interventions for people who use or may use a wheelchair. Our experience in our own research is that people with MS are considering these ripple effects. And if we fail to do so, we're going to have difficulty really making the impact that we hope to influence. Because what they're doing is really balancing the rewards of a new management approach, which in this case we're talking about physical activity, against the additional or perceived burden that may have on other people in their lives, either through the time or travel or other environmental changes. So next slide. So what are the challenges arising from these ripple effects? So my own observation is that typically physical activity interventions are individually oriented in terms of delivery, outcomes, and impact. And we really need to think as we move forward in terms of shifting away from these purely individually oriented outcomes, interventions and outcomes. And there is some exciting new research that's happening from colleagues of mine here in Canada. Falcolade and her colleagues, and one of the collaborators on this project, have been working on something called PAT-MS, or Physical Activity Together. And this is an intervention that was developed after focus groups and surveys of people with MS who experience moderate to severe disability and their caregivers. And in these studies, physical activity was viewed by the participants as this continuum for things that are highly structured, like going to fitness class, to ones that are unstructured and spontaneous, like doing household activities or working in the yard. So participants really emphasized the importance of having supportive social networks and programs to facilitate engagement in physical activity, and really things that were support affordable and joint participation of people with MS together with their caregivers. So the intervention itself incorporates both group and one-to-one, and it's dyadic with both people with MS and their care partners participating together. So I think moving in this direction is really exciting and needs more attention. The other thing we need is to be able to translate to the real world. And there's great examples in Ireland of how they've moved studies of exercise into things that are funded by the Irish Department of Health. Next slide. So time changes everything. Symptoms change, self-management, the strategies that are needed are changed. People's use of wheelchairs change over time as well, and the type of wheelchair and the meaning of that changes as well. Karen commented earlier about the need to normalize the use of assistive devices or other equipment, and I'd just like to emphasize the importance of this. So next slide, just because I'm running out of time here. So the challenges we have for as time changes, we really need to think about how we market and communicate to different groups of people. And we need to really focus on theory-informed and multi-component interventions, which Chuck Bombardier talked about this morning. And we need to think about measurement issues, because maybe maintenance of status is just as good as improving in some cases. Next slide. Finally, we need to really think about building on strengths, because the people who are our stakeholders have many strengths and a wealth of wisdom, and we need to be leveraging their expertise. We really need to, as Karen noticed earlier, we need to have leadership among those who are most impacted. We need to actively participate in promoting their leadership, and we need, if we're going to advance physical activity for people who are using wheelchairs. Next slide. So what are the challenges associated with leveraging? We need to make sure that we have meaningful engagement versus tokenism. And we really need to recognize and value the use of participatory approaches in both grant and publication reviews. Next slide. So in summary, key insights from our work is the patient factors that may influence the extent of benefits or harms of intervention include the extent to which outcomes have inherent meaning to the participants. The participant can consider impact on others in their lives. We take a long view because time changes everything. And the intervention is participant-centered and driven. Last slide, please. So my key recommendations are that we need to include participation as an outcome of physical activity interventions targeting people who use wheelchairs. We need to support studies that follow people more often and over longer periods of time to get variability and understand trajectories. And we need to use a social determinants, participatory, and strength-based approach to ground our intervention, development, research, design, and support scale-up. Thank you.
That was great information. Thank you, Dr. Finlayson. Dr. Brett Smith will now give a talk on gender access and participation in physical activity for individuals who use a wheelchair and are in-wheeled. I'll hand it over to you, Dr. Smith.
Thank you. My name is Brett Smith and I'm a Professor of Disability and Physical Activity at Durham University in England. Previously, I was also the chair of the Chief Medical Officer's Physical Activity Guidelines for Disability. And thank you for the kind invite. I hope everybody's safe and doing well. It's been a tremendous set of workshops so far and I've learned massive. So thank you for a great opportunity as well. Next slide, please. Nothing to declare. Next slide, please. What I want to highlight is that access to physical activity for people with disabilities is partly, I stress, partly hindered and facilitated by gender. I say partly because as we've already spoken, people have already eloquently spoken about, the issue of intersectionality is vital, and I'll come back to this as we progress. Next slide, please. When we look closely at the published research in relation to disability and physical activity, sex is at times a variable that is explored in RCTs, but mostly in cross-sectional research. This said, gender is not often explicitly focused upon in research on access to physical activity participation for people with disabilities, a task that I've been to look at as we speak. But when we look at it, when it is seriously considered, gender is mostly looked at in qualitative research. Now, that research, of course, has much to offer, including, for example, naturalistic generalizability, transferability, and analytical generalizability, all different types, of course, of generalizability than statistical probability generalizability, more associated with quantitative research. Next slide, please. At the same time, I want to extend and complement what many of the speakers have talked about, how we might think about research by bringing into this talk physical activity work I've been doing with colleagues and many of the people have been doing within the UK at the very least, in terms of co-production. Co-produced work is about working with, of course, not on disabled people, to understand, for example, their priorities for research, and how we might work with them to support meaningful physical activity within their local communities to get and to stay active on their own terms. What's interesting within England and in the UK, co-produced research is gaining traction, like in other countries. And that traction has recently led to the UK Chief Medical Officer's expert group for physical activity to conclude that we need more research to be co-produced, including in RCTs. Next slide, please. Turning to work then on gender, access and participation in physical activity for individuals who use a wheelchair. Let me first begin with healthcare professionals. We've found that when people with disabilities visit their GP, their interactions can be structured through gendered assumptions about what it means to be a male or female with a disability. And these assumptions as these quotes suggest, can both facilitate and restrict activity participation. And this is vital to note, because in many countries, of course, healthcare professionals are assumed to be the best messengers of physical activity. Within our work, we found social care and social care professionals have actually been the most appropriate forms of groups of individuals to promote physical activity. But what I'm trying to highlight here is how gender is played out in interactions in terms of health promotion, and clearly much more work needs to be done working with health promotion experts in terms of understanding gender and disability. Next slide, please. We all know that environments can restrict physical activity participation. People have talked about it on many of the sessions that we've witnessed over the last 2 days. But even when environments are physically, structurally accessible, these can still be experienced and felt in and through the body as inaccessible. For example, we are finding from our co-produced research that females often feel scared in certain spaces they should be active in. Disabled females, and especially Black and Asian disabled females, at least within England, can experience what the feminist disability scholar Carol Thomas calls psycho-emotional disablism. For instance, when faced with people staring at them in spaces they want to be active in, or when faced with hate crime, which is sadly on the increase in the UK, or negative comments, females with disabilities are made to feel devalued, alienated, worthless, and fearful of their lives. So the upshot is that structurally accessible environments they're no longer accessible, partly because of gendered interactions. Next slide, please. We've also found that with males, gender assumptions about what it means to be a good dad, for example, in contemporary society, can help as well as hinder and motivate them to become more active. For instance, the reasons they become more active is not so much always tied up to improving their health, and that of course is a key message to people in this audience, but rather is about having a body that can practically enact what it means to be a good dad. And part of that in society, of course, is tied up with hegemonic forms of masculinity, and is tied up with playing sport and being active with children. So there are important lessons to learn, I would suggest, in terms of health promotion and how we can work with males in terms of promoting physical activity, tapping into, for example, the ideas around the pragmatic body. Next slide, please. Humans are, of course, relational beings, but we are also gendered relational beings. And this is played out in the research we've done and other colleagues in various ways. And one of these is that females with disabilities are often full-time carers of families. And this is often the case anyway, including within non-disabled families, with non-disabled females. But in many societies, the assumption, informed, of course, by historically gendered stereotypes and power that then grants males power, is that females do the caring. So just like non-disabled females, this can limit participation for females with disabilities, who spend much of their time and energy caring for their own families, often ignoring their own needs. At the same time, many females are employed as carers. And of course, what that means is that there are spaces that they cannot enter into, which in turn means that for males with disabilities who largely employ female carers, their world shrinks. And it shrinks in terms of where they can be active. Once again, we see the gender dimensions being played out here. Next slide, please. Another issue to consider when thinking about physical activity participation is menstruation. Although there's little research, some of the work we've done has highlighted how menstruation is, for some females with a disability, a double taboo subject. That partly because of embarrassment and or limited knowledge in relation to healthcare professionals, it's tied to how can we be active when our period starts. We may be embarrassed, as some people have said, and we really don't know what to do. And that, what we're finding, is hindering, in part, for some females with disabilities, physical activity participation. So I ask you to reflect on how often we talk about menstruation when it comes to supporting disabled females to get and to stay active. At least in the UK, very rarely. Next slide, please. Finally, I want to highlight the need for inclusive messages, and particularly inclusive messages in this scenario about sedentary behaviour. Too often we find that our messages are ableist, in that they assume a certain type of body, a body that can walk, for example. Ableist messages, which of course are a form of discrimination, include messages like sit less, stand more. With disability rights, we've challenged such messages and are changing the sedentary behaviour messages by Public Health England and our UK Chief Medical Officers so that they can become more exclusive. As you can see in the co-produced infographic that we've developed with over now 700 disabled people within the UK, it's co-produced. Next slide, please. And I share this co-produced infographic that is used by Public Health England, numerous health agencies, disability, sport and physical activity organisations in the UK and elsewhere, because what was interesting when we co-produced it was that females with a disability often initiated conversations about inclusive messages and the importance of communicating. For example, messages that stress physical activity can make you feel good. That is rarely the case in many of our public health messaging within the UK. It's a forgotten messaging. So as an aside as well, the WHO guidelines have come out, and what's interesting from the UK is how those guidelines echo many of the research that we had done in relation to the Chief Medical Officer's disability guidelines. But for me, what that shows is not just the value of evidence-based research, but also the value of co-produced research and how we need to do more co-produced research rather than having this tokenistic view that is sometimes, sadly often goes with some forms of participatory action research. We need to do good, challenging co-produced research. That is, of course, also aligned with evidence. Next slide, please. Next slide, please. So my key recommendations are, of course, sex is a variable often utilised in some cross-sectional research and in some RCT research. But we're not looking at gender as often as we should. The qualitative research is picking that up and talking about it much more frequently in terms of multiple and intersecting identities. We need to emphasise gender much more in our public health promotion campaigns, is what I'm witnessing and hearing from many of the disabled people I'm working with in terms of the co-production. And that leads me to one of the key recommendations is that we need more co-produced research as part of the raft of different participatory approaches. And that includes RCTs. There's some interesting research that we're trying to work on right now in terms of how we can construct RCTs with disabled people from the very get-go right until the end. How can we co-produce good, reliable, useful RCTs? Thank you for listening.
Thank you, Dr. Smith, for that information about gender access and participation in co-produced research. Next, we'll have our final speaker for this key question session. Join me in welcoming Mr. Devin Palermo, who will share his screen as he presents Adaptive Fitness Safely and Effectively Bridging the Gap to Fitness Following Therapy. Following his presentation, we will have a discussion session on key question 3. I turn it over to you, Dr. Mr.
Thank you very much. I really appreciate the invite to come and speak, and I've really enjoyed the presentations so far that have been happening, so thank you. Let me start my screen. So as mentioned, I'll be speaking on safely and effectively bridging the gap to fitness following therapy. My name is Devon Palermo. I'm a licensed physical therapist assistant and a certified personal trainer specializing in adaptive fitness. Disclosure, I'm going to have some pictures and videos, and all of the pictures and videos that I'll be sharing are current clients that have signed release forms and are okay with use for promotional and educational purposes. For knowledge gaps, I'd love more awareness on qualifications of adaptive fitness, of current adaptive fitness opportunities and the qualifications of the programmers. Moving forward. So as mentioned, I'm with a company called DPI Adaptive Fitness, where the focus is fitness for everyone at any level of ability. I mentioned I was a licensed physical therapist assistant. I spent many times working in the inpatient and outpatient physical therapy units at a rehabilitation hospital. And back in 2005, I was working with a patient who her insurance had lapsed, and there was so much potential for more outcomes that were really left on the table because the insurance had been cut off. What was decided at the time was that we would continue with exercise-based programming in the patient's home several times a week for months until insurance was reinstated. During that time, just focusing on cardiovascular strengthening, on strength training in the home, we were able to see an improvement in the individual's functioning and more outcomes. So as therapists, when someone is discharged from therapy prematurely and then returns, we typically see a decline in function, and then we have to work on building back up. In this case, the evaluating therapist saw improvement, and because of that improvement, the therapist was able to focus on new goals and address new, different outcomes. And it was all because of the strength and cardiovascular endurance training that this person had done in the home. That caught on, and more people started reaching out. And so, as mentioned, in 2005, I just really recognized the need to bridge that gap. We know that there's adaptive sports, but there's a lot of individuals that do not pursue adaptive sports that really want to look at continuing to maintain health and function, and so that was a big address, was to bridge the gap between traditional therapy and fitness, all while providing great exercise resources for individuals living with different abilities, following or in addition to their current therapy. I always say, if an individual is focused on fitness while they're still in therapy, the outcomes can be so much better. And even post-therapy, as we all have heard and have been discussing, we're only going to see great benefits in fitness from physical activity. A need also recognized to have qualified adaptive trainers with background in rehabilitation. I noticed when I was, initially researching fitness training, there weren't many trainers that focus on adaptive needs. And there were a lot of the certifications that are out there, a lot of the programming that's out there really just scratched the surface. So really having a qualified adaptive trainer that has that background in rehabilitation, that understands all of the comorbidities that have been discussed, that we all know, the precautions and the limitations that individuals may have. I feel like that's a big need and one that I definitely wanted to be able to try to bridge that gap some. In addition, to be able to collaborate with PTs and OTs and doctors to enhance patient progress while they're in therapy, and even, as I mentioned, post, when they're discharged, have therapists, inform the trainers, what can we continue to do to fose on that next step? If they're done with therapy, if they're no longer going to be coming back, what's that next step that we can keep them physically active to decrease those comorbidities? And then just to really empower an individual. We know the benefits of adaptive sports and how it empowers individuals. But again, for those that do not participate in sports, how to empower individuals through training, whether it be one-on-one or in small group sessions or large group or even community-based programming. The strategies that are focused on here, I really enjoyed some of the discussion on the dosing. I feel like we try to be very intense with our programming here with, again, the safety in mind for each diagnosis, for each individual, following a baseline assessment. So all of the assessment tests that were mentioned with the 6-minute walking test and for ambulatory users, or even if you're a seated user, different cardiovascular tests or functional movement tests like transfers or floor transfers. We focus on doing baseline testing so that we can be able to intensely within safe parameters, push individuals to progress. For those individuals that are focused on neural recovery, it's a big focus on neuroplastic exercise. So high repetitive, task-specific functional movements that are compound-based, so requiring multiple muscle groups over multiple joints. And then again, for those that are not focused on neural recovery, it's us performing or programming adaptive fitness that is focused on maintaining health, wellness, functional ability, while all the while making sure that that we're decreasing the likelihood of injuries. And we do that through having a deep understanding of risk precautions associated with diagnosis that are commonly seen in this adaptive fitness setting. A big focus of what bridging that gap is from therapy to fitness is one-on-one training sessions. The sessions here are focused, they're individual, they start with baseline assessments so that we can gauge how hard to push individuals or how we have to back off and maybe ease into it. A big thing that I like to stress with assessments are exercise history. So pre-injury or pre-meeting us as trainers, what your exercise history is like. If I know that you're an individual that is into adaptive sports, or that previously before injury was into sports and understanding what it takes to compete at a high level, then as a trainer, I know that I can push. I just need to be aware of the medical condition to make sure that we do it safe, but I know that I can push. If it's someone that is an admitted couch potato or sedentary person, then I know that I'm going to have to back off and kind of go really slowly. So that in terms of programming dosing, that is going to tell me, that exercise history is going to tell me how I can start with the programming. But the one-on-one sessions are focused on, according to goals that the client addresses and that the trainer kind of defines as well, improving strength, endurance, balance, recovering as much mobility as possible, and really increasing confidence and overall function. A great story about this individual that's on the right here in the red shirt. We started working together nearing the end of his traditional therapy session, and I met with his therapist, and his therapist was focused on bed mobility, rolling, and he was a newly injured C6, C7 incomplete quadriplegic, and I inquired about movement below his injury, and he had some. So we took some steps and focused on just repetitive standing exercise, just standing endurance. Started with 2 minutes, built up to 10, to 15, to 30, to an hour, to the point where I can set him up independently on the on that cage, as you see there. What it did was it took through repetitive movement and working intensely. Initially, that 2 minutes was very stressful and strenuous, but we got to a point where we can build up endurance, standing endurance, tolerance, so that he could maintain for an hour. What that did was that made it so that he basically got 40 minutes back in his life, in his day-to-day. We took out the 20 minutes in the morning and the 20 minutes in the evening of using a Hoyer lift. We made it so that his very petite wife can do a stand pivot transfer with him. And that was all through, just being intense to his level of ability at the time and building on it. I'm going to move on. Some other things that we focus on, and we'll see in this video here, this individual is diagnosed with MS, and upon discussion in a group setting mentioned that it had been many years since they had gotten up off the floor, and the last time that they had to do so, they couldn't do it, required the assistance of the individual's son, and just stayed on the floor for a number of hours. So through small group training and kind of individualizing the program, we were able to see and build strength and then apply and try it. And as you'll see here, this is this individual's first time attempting a floor transfer in many years. And this is just through, I turned the volume off, but this is just through instruction, hands-off approach. And again, I was able to individualize it because I saw what she was able to do during the course of a small group session, and she was able to complete that transfer. There we go. Perfect. In addition, you know, I feel like for one-on-ones, like, again, this is another incomplete quad, and the benefits of one-on-one sessions is that we're able to do things that typically in therapy settings, there's not a lot of time for. So I really feel like safe transferring to the floor and having this individual practice loading through his knees and bearing weight and getting down into that position in a safe manner is something that it can be done with qualified eyes, with a certain amount of skill and trust from the trainer and the individual to perform this movement. All right, moving forward. Some of the other programs that we do for those that are not able to focus on the one-on-one sessions, there's a lot of group programming, like I mentioned earlier. And I love the small group programming because I feel like people play off each other's strengths and they communicate with each other. And again, we're talking about individuals that maybe are not into a higher level of sports. And so, you know, it's the physical activity to maintain their current abilities. So we have diagnosis-specific classes like MS class or Parkinson's class. We have all abilities classes, like in the top right corner there, you'll see in a beginner adaptive boxing class. And what's great about it is that everyone is performing at their highest level of ability in a group setting, encouraging one another. And I think that just builds on an individual's confidence and commitment to continuing exercise. So it's almost like we are a sports team when we're in the gym together working out. But what I like to do is I like to really stress benefiting individuals by individualizing it in group sessions. So I'm going to speed through this a little bit. This individual is in a staggered stance, focused on balance training to improve and feel more confident. This individual is working on rotation through balance with doing boxing. So we use a lot of traditional exercises and boxing drills, but that apply to these individuals' functions and abilities. So here you see the wheelchair users, we're working on building up trunk stability and strength. And we're doing that through exercises where they're not focused on their strength, they're focused on the task at hand, but it's directly applying to what we're looking at. I think my video is not working there. And I know I'm stuck on time. Move forward. Some of the other things that we do is focus on adaptive events to try to build the community and get more individuals to be as active as possible. One of our big events that we do here is called the Adaptive Fitness Games, and it's a set of different challenges that allow individuals to come and participate in at all ability levels: ambulatory, wheelchair, power wheelchair, scooters, and there's individual stations that people can participate and do their best at, and there's a crowd encouraging you. It's a real sense of community. And then we do a tag team event where we have trainers pair up with participants so that everybody is very inclusive. Everyone's working out together. We do events like potlucks to build that community more and talk outside of a traditional gym setting. And then I'll just highlight some workout sessions. I know I'm running short on time here. I'm hoping that this works. Oh no. Let's try this. Apologies, everyone. Oh, here we go. All right. So just highlighting the hard work in a typical week at the gym here, all ability levels. And what I'll say as you're viewing this is just in conclusion, you know, what I feel confident that I can say is that physical activity, when guided safely for wheelchair users, does improve strength for function. It does improve strength for recovery, for improved socialization and increased confidence, which in turn creates more opportunities for individuals to have additional physical activities that previously they may not have even considered. I'll let this video pan out, and I thank you guys for your time and attention, and I'll go through my last slides here. A couple more highlighted shots, and then we'll move on. Perfect. So I think the biggest thing, biggest key recommendation that I would say among all that I have listed here is an increase in research on intensity and dosing for adaptive fitness. I know that that's been discussed earlier, but I would love to see more of that, and definitely, you know, just the role that adaptive fitness outside of a therapy setting has on individuals' function. And again, as mentioned before in earlier settings, it depends on the individual, whether it's, you know, focusing on increasing strength for function for just regular ADLs, or for, you know, leisure activity, or for competing at a high level. But again, I think there's current research that I follow on neuroplastic changes and high repetitive drills for stroke survivors. I'd love to see more of that for all abilities, as well as the benefits of high intensity interval training for spinal cord injury and different wheeled wheelchair users. So thank you all very much for your time, and I appreciate the opportunity to speak.
Mr. Palermo, thank you for your presentation on the benefits of adaptive fitness, and thanks for sharing those videos of examples of individuals improving their fitness. Okay, so now we're going to go to Dr. Gerwitz, who thank you in advance for moderating key question 3 with our speakers. We want to invite all the speakers to join the discussion session now. And to all the participants, thank you for submitting your questions and comments in the Q&A pod. We will continue receiving your questions throughout this session, so you may begin, Dr. Gerwitz.
Okay, and thank you very much, everybody, for those presentations. They were really, truly inspiring, so thank you. Keisha, can you just give us a time check, how we're doing on time, where we're going with time?
Certainly. So we have 40 minutes now. So I guess I will say at 3:40 we will end our discussion session.
Okay. So as before, what I'd like to do is to begin with the panelists, and also please send your questions along. And I'm going to try to do my best to multitask, so I appreciate you sending those questions in, everybody. Okay, so I'd like to begin with Daryl, if you're there.
Yes. I just want to thank the panel, a great panel, great discussion. And Devin, I certainly do appreciate the videos that you were showing. You're making me feel missing the gym activity that I normally would do during this this pandemic, and so I hope everyone was sort of equally inspired. I have a couple of questions. One is with to Edward. Does health literacy, you talked about cognition, but does health literacy play a role in on how physical activity can either in both the translation as well as in its actual impact?
I think that's an excellent question. I think that health literacy can be adapted to various cognitive levels, and I think that's something that we need to think about in dealing with individuals with disabilities that involve cognitive impairment. I think that there's I think Dr. Smith also talked about some different approaches to motivating people to get involved in physical activity. So I think when we think about different cognitive levels, how we can express the ideas of health literacy in terms of what the goals and outcomes would be in terms of what that person would value, I think can be very important. I also think it's important to, just thinking about some of the discussion we've had about ableism, I think it's also very important to frame people's understanding of health outcomes as part of their health literacy in terms of not, understanding that their outcomes may be different than folks who do not have a disability, but that we can talk to them in terms of outcomes that are valuable to them.
Right. Thank you. And thinking about sort of the impact of the social determinants of health, and so is it really just on the access side, or is it also on the impact of the intervention itself? And I was intrigued not only, I guess, in thinking about it from an individual point of view, but I think both Marcia, when you were sort of talking about how the impact of MS is not just on the individual, but on the family. So could you talk a little bit about how these we can think about these social determinant or social determinants of health, how they impact sort of how the intervention, the translation, if that makes sense to you.
Yeah, absolutely. So the comment that I made in my presentation is that, our experience in the work that we do is when we were trying to provide people with MS alternative strategies or new strategies to incorporate in their regular routines to help them manage symptoms, what was happening is they were making decisions about what strategies would work or they were able to incorporate based on how it would affect other members of their family. And so I think when we're looking at physical activity interventions, especially given what others in the panel have talked about in terms of, accessibility and need for help with transportation, the costs of equipment, if we're not taking into account how the suggestions or the physical activity intervention, what the ripple effects might be and how that might influence the way people think about whether they're willing to take that on. So if you think about potentially a parent who has a young child that needs other kinds of, they need tutoring or something, and I'm either going to buy a piece of equipment to support my physical activity or I'm going to buy my child the tutoring that they need, I think we have to think about the fact that people make decisions about what they do in the broader context of their everyday lives. And we need to consider that and talk to people about, maybe alternatives. So I hope that helps.
Mm-hmm. Devin, with regard to, you had mentioned something about insurance, your clients' insurance running out, and in some ways a motivation for the work that you're currently doing now. And I was just trying to think about how accessible is the kinds of the services. I mean, is it really, very expensive for persons to participate in the types of programs that you're offering?
So I feel like we're very fortunate here to be able to have lots of options for the participants in the area and now virtually. We're partnered with the local rehab hospital that is providing much of the programming, large group programming that we do at no cost to individuals. So that's one of the ways. In addition, we've partnered with a nonprofit in Florida to offer virtual programming at no cost. and a local nonprofit in the area to provide scholarships for one-on-ones. So that's for individuals that do have or have a harder time accessing funds for the sessions that we do. Most everyone, it's self-pay. For the one-on-one sessions, it's obviously, rivals what it would cost for therapy, if not a little bit cheaper. But we do nominally priced classes so that really all levels, whether it be ability or financially, can participate. So I feel like it's pretty accessible.
Thank you.
So I'd like to ask a few questions if I could, and I'm going to try to be articulate, although I'm not sure I can be. I guess I want to ask each of the presenters to respond to something I'm struggling with. And I'm trying to reconcile what I'm hearing relating to the systematic review that's been presented to us with what you're presenting to us. And what I'm hearing in the systematic review is a focus on outcomes like heart attacks, the occurrence of diabetes, obesity, things like 6-minute walk times. And what I'm hearing from all of you is something that seems very different. Outcomes that matter most to me. Things like participation, sexual function, being a good dad, standing. And I'm wondering if you're feeling a disconnect between the way you think and what's being presented in the review, or whether how they align or not. So let me just start with Ed. Maybe Ed, you could respond, and then we'll go down the list.
Yeah, well, Jerry, it's a matter of the research into the goals that you're talking about is just not as available. It's not out there as much as we would like it to be. So I was involved in an effort a few years ago called Research CP, which was a gathering together of professionals, researchers, clinicians, and community members who talked about prioritizing research for people with cerebral palsy. And there was no question that participation goals were the thing that rose to the top, and that may be influencing how I'm presenting. But the literature is rife with the body composition type goals, the other end of the ICF diagram. So I think that's something we need to work on, but it's a significant challenge because it's so multifactorial. And I know, like when Dr. Blauwet presented earlier today, studies about participation in sports leading to greater participation, there's it's sort of a correlation, but causative is very hard to say because there's so many things that go into those kind of things. However, it just gets harder. Doesn't mean we shouldn't do it.
Marcia?
Yeah, I totally agree with Edward. I don't see it so much as a disconnect, but I see it more as a fundamental difference in paradigm or worldview. So when you look at the outcomes that we have seen in the reviews, the systematic reviews, it has a very biomedical orientation. They're nice, they're objective, you can count it, you can see it. The kinds of things that we've been talking about in this panel and some others have talked about is really a much broader, biopsychosocial, social model of disability perspective. And like Edward said, these are messy and they don't fit nice and cleanly in our very traditional, positivist view of research. I don't think that means that we should not do them because they're messy. I think we need to recognize that there's different worldviews and they're all valuable for different reasons.
Brett?
Yeah, I echo all those comments, and just to reinforce, for me, there's nothing wrong with systematic reviews. We need them. We need these certain outcomes, such as obesity, heart attacks. Those are absolutely fundamental. But at least within the UK, I speak from a very UK-orientated perspective, of course, and disabled people have a large voice, and for them, those types of outcomes are driven by economic needs from our government. They're not driven by their own needs themselves, their own everyday needs. So they don't really resonate, those types of outcomes, with disabled people. So when you're asking them, what are your research priorities? What are your outcomes that you value the most? Heart attacks, obesity aren't really on their agenda. They're important, but they're in the background. So for me, in terms of health promotion and public health, and in terms of trying to engage people to become more physically active, questions that I ask are, what are meaningful to you, and how can we work with you in terms of producing and having better outcomes that will impact on your lives, rather than me assuming what I think is the best type of outcome in relation to this. So I think, at least within the UK, and particularly within our Chief Medical Officers group of physical activity, we're having readdressing the balance in terms of what are the significant outcomes. They are still significant, but we should also engage with some of that messy, troubling work that doesn't sit too well in the types of work that has been underpinning all these workshops. So for me, it's an incredible privilege to be able to lend our voices to these troubling waters, which makes your jobs much more challenging. Thank you.
Thank you. Devin? Maybe you're on mute.
Apologies. I said, I'm echoing everyone else's response. I think those are fabulous answers. I think when it comes to the participants that I work with, while that is important, the focus on outcomes and improvement tend to be the first objective or goal that they have. And then as continuing on with education and sessions, all of the other, heart attacks and the comorbidities, that comes into play a little bit more, and people understand why it's so important. So I think in my setting, it's more, it's education based. So as they continue on, they learn a little bit more about why it's important and why it's important to understand and have researched, for end results for heart attack and all that.
Thank you.
Dr. Gerwitz, can I just add something else?
Oh, please.
Yeah, I think the other thing we have to acknowledge is that, this isn't any different than any of the rest of us. I suspect that most people who are participating today or listening in, if you are regular exercise, you're not doing it as, I'm going to the gym so I can stop that heart attack I might have. No, we're doing it because we want to be able to do things with our friends or with our family or whatever else. So I think we need to be very cautious about this dichotomy that because people have disabilities, we have to focus on all of these negative outcomes, but for ourselves, we do it for other things. So I just want to point out that that's also something we need to give consideration to.
Thank you, Marcia. I'm going to turn to the rest of our panel. Boris, any thoughts, comments, or questions?
Yeah. Daryl, to a large extent, sort of took my question, which is I just want to delve a little further into the issue of health literacy as a patient, as a factor of individuals, obviously, who are getting information to them and processing that information, and whether it's understandable, right, a patient factor, a component of this. But, again, to anybody out there, how is it that we can get better on the health literacy component? And whose responsibility is that for expanding health literacy as a key component of physical activity for wheelchair users in particular?
Well, I think it's the responsibility of all of us that provide healthcare. And it's our responsibility to give that information appropriately to the patients that we serve. And I think that one of the issues that I talked about, the cognitive issue, people with cognitive impairment, but we also talked about the idea that the health literacy we have that relates to physical activity, we don't have the guidelines in place, proper guidelines in place for people with disabilities. And we just need to keep expanding that information so that we can be more literate in our health. health literacy about physical activity with disabilities is not just an issue for the people with disabilities, it's an issue for the healthcare providers who also lack the information.
Let me turn now to Kirsten.
Hi. Oops. Thank you, everybody. My question is somewhat coming back to something that Jerry raised earlier. And I'm wondering if, what each of your opinions are on whether RCTs are actually getting in the way of the research that you really need to be doing. So I'm hearing that, there's a real need to measure participation as an outcome, that we need to focus on social determinants, we need to take a participatory approach, we need to be looking at differences more, similarities, differences across various groups. And, are we shooting ourselves in the foot trying to focus on RCTs? Or is there another solution?
So it's Marcia here. I don't think we are. I don't think that those things have to be on a dichotomy. I think, where we can improve our use of randomized controlled trials is looking at adaptive designs. There's some very sophisticated RCT designs that are coming out now that I think we need to, learn more about and figure out how to use more effectively. I think we can use participatory approaches and co-design with stakeholders to design really meaningful randomized control trials. And, Brett's probably in a better position to talk about this, but I think we have to get out of the RCT looks like a drug trial and move into more sophisticated kinds of looks about what that could be.
Anybody else want to chime in?
Yeah, I'll just, Brett, thank you. Sorry, it's my 12th hour behind the computer. My voice is cracking after speaking to students and giving 2 of the talks today. I think it's an excellent question, particularly given the cultural context, which we're slightly different in the UK in terms of how we treat methodologies. Maybe it's the same in Canada on this. And of course, it comes back down in part to Bush's No Child Left Behind Act in terms of education and having RCTs in terms of the dominant hierarchy and the politics behind that. For me, RCTs are incredibly useful. They can answer some really important questions about the fit components that we need, and when they're done well, unequivocally, we need them. They answer really good questions. But as everybody said, and I think I'm just repeating it, they're not the only way. And for me, and certainly the disabled people that I work with, I said disabled people, in the UK it's disabled people, it's different terminology. It's much more of a flattening of methods and methodologies. We don't have a gold standard, and the variety of different ways in which we can go about doing research to answer different questions based upon different paradigms, based upon the research priorities that people with disabilities ask for. And so for me, it's not straight away go to the RCT. The first point is, well, what type of questions are we asking? Where do we want to go with this? What's useful? Rather than a default position. And having worked in a medical school, I appreciate the default position is generally RCTs based upon pharmaceutical work. But I'm asking for, let's think it's an and, is what I'm trying to say, an and approach.
Yesterday we talked a bit about registries during the question and answer session in one of the sessions I listened to, and I think that's something important for us to think about in terms of pragmatic trials. And the power the registries give us to have those kind of trials, comparative effectiveness research, and so forth. And I think that's all going to become something we need. It's very, very important, especially with some of the populations we deal with that are not large numbers that really allow us to do large randomized controlled trials.
Thank you.
Thanks, Kirsten. The other thing, just to follow up on Kirsten's point, I think I was hearing from Marcia an advocacy for individually tailored interventions. And is that something that resonates with all of you or not in regard to doing studies, even RCTs in this population or these populations? Marcia, do you want to respond?
Yeah, like I think for me it's a combination of the it's the individually tailored intervention, but it's also the individually tailored outcome, so which makes it really difficult, right? But people want to engage in physical activity for different reasons, and somehow we have to be able to acknowledge that. I do struggle with how do you do that in a consistent and rigorous way. And I think it goes back to Kristen's question just now about randomized controlled trials. But you're going to have, if you look at the individually tailored interventions, people have different needs at different points in their lives. And so, you may be able to have some kind of consistency at different points or for addressing different issues, but that's going to have to evolve as people change in their, ability level or comorbidities or whatever change as well, or the life context that they have. So it can't be a one size fits all.
Thank you. I'm going to turn now to Kelly.
Yes, I had a question for Mr. Palmero. Yesterday, one of the speakers mentioned that in randomized controlled trials of MS participants with an exercise intervention, that there were individuals who had no change or detraining on outcomes like a 6-minute walk test or fatigue. And I just wonder if that's been your personal experience and what reasons could be behind this.
That's a great question. And I think, just piggybacking off of Marcia there, I think that it depends on the individual. It's definitely depends on that individual and what they're doing to progress, to work. If they're being consistent with their programming, I think that's the biggest thing that I've seen is consistency. Those individuals that are consistent, are doing the programming, are doing the assigned work outside of the gym, are showing improvements. Those that are just focusing on what their therapist have them do during a session or what they're doing here during their 60 minutes with us or in a group class, they're not seeing as much a benefit. It's definitely, and we stress that here all the time, consistency is key. And we all know that with everything that we do.
Thank you. Watching the videos that you showed, it also made me think maybe the exercise that's being given is not the most appropriate for that person.
It can be. I think a lot of the programming that I like to focus on personally applies to direct function. So whatever that individual doing a baseline assessment, whatever they have difficulty doing, that's the focus that I'm going to do with the strength training. So if they're having a hard time sitting to standing, they need their arms, we're going to work on tricep strengthening and depression, pushing down, and leg strength. And that usually complements and takes them forward.
Direct strengthening, is that the term you used?
Direct, yeah.
Direct, yeah. Okay, thank you.
Yeah.
Noelle?
So I wanted to go back to the question that you asked, Jerry, and sort of extend upon it. So one of the things that Marcia talked about, and actually Chuck talked about as well, was the need for a focus on theory-based interventions. And then, Jerry, with your question, you were asking the question we've asked as a panel about sort of reconciling the systematic review with a lot of the information that we're being provided in the presentations. And so I was hoping to just hear a little bit more about sort of thoughts about what, if we're going to focus, what we need to focus on in terms of theory-based interventions.
So, Chuck talked about some great things this morning in terms of the self-efficacy and using goal setting and problem solving. Certainly in my own work, which again, I'll just preface to say that my own work is not in physical activity. But, we use a lot of principles and theories of adult learning, getting people when they're ready to make changes. We use a lot of change theory. So looking, and Chuck talked about this morning, like you have people who are not quite ready and we may need pre-interventions to get them to a point where they're ready to be able to move forward. Certainly we've used a lot of goal setting theory in the interventions that we've done in terms of fatigue management in MS, and I think they would very much apply in the context of physical activity interventions as well.
Just as a follow-up to that, do you also think that in the context of the discussion about sort of the biomedical model versus the biopsychosocial model, is it possible for us to meld those two things, like focus on goal-based interventions that encompass more outcomes, I guess, might be the focus?
Yeah, I think that fundamentally when you're doing some of those broader, like when I think about using, like an environmental press model to be able to guide the intervention, you have to take into account environmental factors. So that is likely to change the kinds of outcomes that are going to be of interest. And I might use those theories if what I'm doing is trying to help people overcome barriers, environmental barriers that are preventing them from doing the things they want to do. So I'm not sure that quite gets at.
I think it does. No, thank you. I think that's helpful. Thank you.
I would just add that I think that what you mentioned, Dr. Colosi, about the biophysiological outcomes as well, I think we really do have to meld those things so that we understand that we're getting past the barriers that keep people from and being involved in physical activity, but then also driving them toward physical activity, which would be most beneficial for some of the conditions that I talked about when I presented.
Thank you.
We've received one comment from the just received a comment from the audience, and this is really an important observation, and I'll just quote it. There is often a lack of assessor blinding in studies, that there are daily fluctuations in performance, which can be great, and regression towards the mean is a real effect. Any comments from the presenters? Those seem like important points.
Yeah, I think, I feel like I see that pretty often myself. I'll have an individual come in and you feel like he's regressing and not performing at the level he was the week before, and that's definitely recognized and noted. And then the following session, he'll be able to perform a little bit better than the previous session. And it definitely, I completely agree. I mean, regression towards the mean is a real effect, and I've seen it in here. People come in a little bit weaker sometimes. It just helps them to improve for the next session around mentally.
Let me ask all our workshop panel members if they have any other additional comments or questions. And then I'm going to ask the presenters if they have any final comments, and then we'll close for today. Anything from the panel members?
I just wanted to just probe a little bit on the GMF CES 4 and 5 persons who seem to be understudied. And so could the panelists just talk a little bit about does that mean that we need more RCTs that focus on this particular group? What's really the barrier here in terms of studying this group of wheelchair users?
I don't know that if RCTs are the issue is as much as even more feasibility studies and just observational studies to get people involved in programs and see what kind of changes occur. I think there's a lot of information that we need to gain to understand what kind of question we might have that would come to the level of an RCT. Just trying to see which ways to get best exercise effect. That was the first study that we tried to do, and that was just one small effort. And then thinking about different different ways that people that are wheelchair users with cerebral palsy can get more involved in different sports at that GMSCS 4 or 5 level, different kinds of physical activity. I think just looking at effect of just breaking up sedentary behavior and putting physical activity into the day are some of the first things that we need to do.
Thank you. Okay, last call for questions or comments.
Dr. Gerwitz, I would like to add something about the future for systematic reviews. That the review we did here did focus on randomized controlled trials, but very often we do include non-randomized studies in systematic reviews. And recently we've been developing methods to incorporate qualitative studies and undertake qualitative analyses in reviews. So in the future, that might be very helpful here.
Thank you.
I'd just like to not add to that, but it was interesting that for the UK Chief Medical Officer's Physical Activity Guidelines that came out in 2019 that I was a part of, the case was made to include qualitative research. Of course, the quantitative research was graded accordingly and quite rightly in terms of RCTs, cross-sectionals, etc. But qualitative research was included to add some more depth and nuance to appreciate other sides of the complexity that just RCTs or the lower level quality types of studies couldn't get at, and added another complementary approach to making it a strong public health document, or as strong as we could with the available evidence on that. At the same time, we're equally cautious, and I'm speaking as the president of the International Society of Qualitative Research in Sport and Exercise right now. There's a lot of work being done in terms of systematic work and utilising qualitative work. We need to be incredibly cautious in terms of using certain checklists as well, because some of those checklists that have been perpetuated, sadly, including by some senior people within the UK, are rather outdated. So I think if you consider going down the qualitative route, certainly appropriate experts, and you've got people on this call from the US that would be applicable to be able to judge what counts as good qualitative research. I think that's absolutely crucial, and that's what we found within the Chief Medical Officers group within the UK.
Thank you, everybody. Keisha, I'm going to ask you to close out the day and give us our instructions and prepare us for tomorrow.
Okay, I think we had one more question. Are you able to address that question or pose it to the panel?
The question I saw did relate to the last comment, so I think it has been covered, yeah.
Okay, thank you. So thanks, everyone. Thanks, Dr. Gerwitz, for moderating that great session, and thanks to all the panelists and speakers who provided their responses. So how's everyone feeling after completing 2 days of the workshop? Well, I'm feeling excited, I feel knowledgeable, and I feel accomplished. I thank everyone for hanging in there with us, as we had to get a late start today and extend our end time. But I hope you're looking forward to our third and final workshop day tomorrow. So before we end, I just want to cover what to expect tomorrow. So if you've already registered for day 3, you should have received a reminder, including the link for the workshop. We ask that you please join us at 10:55 so we can start or begin promptly at 11 a.m. We will cover key question 4. And we will be hosting we'll cover key question 4, host a lightning recap among all the speakers, and hear final words from our NIH co-sponsors. If you're not already registered for day 3 and would like to join us, you can register at prevention.nih.gov, and we put that link in the chat as well. If you have any questions about the workshop today, or about any registration questions, a technical question, feel free to send us an email at NIH P2P at mail.nih.gov. And I want to thank everyone for an excellent day. And one more reminder is that you can also comment on the EPC draft systematic evidence review at the website that's on the slide here, and also we'll post it in the chat box. But everyone, have a great rest of your day, and we'll see you tomorrow at 10:55.
Thank you.
Thank you.